Hello. Good morning, everyone. You're all warmly welcome to day 2 of our AGSM. My name is Sheila Tukwefio, and we are the moderators for this morning's program, together with
Dr. Gordon Menomponsa.
So we'd like to start the program with the opening prayer. We'd like to call on Dr. Isifu Amwaba to give us the opening prayer.
Let's pray. Heavenly Father, we thank you. We bless you for this morning. Thank you for day 2 of our program. Holy Spirit, we pray that you take over, come and lead us. We pray that let everything that is done here be unto your glory and for the advancement of cardiovascular health in Ghana and the world as a whole. We give you praise, we give you glory. In Jesus' name, amen.
Thank you very much. Would like to introduce the chairperson for today's activities. I would like to call on our LOC chair in the person of Dr. Foster Foucault to introduce the chairperson for today's event. Please let's give him a round of applause.
Good morning to everyone. And I have the privilege to introduce the chairman for today's activities. He's my own boss, Dr. Amable. Dr. Eugene Amable is a consultant cardiologist and a fellow of the Ghana College of Physicians and Surgeons, as well as a fellow of the West African College of Physicians. He worked in the Kolebu Teaching Hospital, where he served in various capacities, including lecturing in the medical school. He previously held the position of Chief Examiner for the Faculty of Internal Medicine at the Ghana College of Physicians. He served in many capacities on a national scale and has been an instrumental person in training many physicians and cardiologists in this country. Amongst them include Dr. Jekum. He started with Dr. Jekum, then followed by Dr. Abba Forsen, then myself. He's done a great job with respect to cardiology training in our country. Ladies and gentlemen, let's welcome Dr. Eugene Amable as our chair for today's activities.
Thank you very much, Dr. Foku. And again, good morning to everybody here present. Welcome to the second day of our annual general and scientific meeting. Those of you who were here yesterday, I'm sure will testify that we had a very instructive session looking at various aspects of our theme for this year, Atherosclerotic Cardiovascular Disease. So yesterday we were taken through the basics, pathophysiology, epidemiology, and then we went on to look at various aspects of ASCVD, including stroke, acute coronary syndromes, and so forth. We are continuing today with this same theme, and this morning we shall have presentations on peripheral arterial disease and also on imaging, after which we'll go on to another session where scientific abstracts will be presented. So without further ado, we shall move on to the first session, which will be a presentation on peripheral arterial disease. And for this, we are honored to have with us Dr. Lily Wu, who has had a scintillating career in medicine, starting from medical school where she graduated with honors, winning several academic prizes. She then went on to specialize in South Africa, where again she did the same thing, won gold medals in various aspects of vascular medicine. So she's a fellow of the West African College of Surgeons and a member of the Ghana College of Surgeons. Also has a postgraduate MPhil vascular surgery and endovascular surgery from South Africa. She's presently at the Kolebu Teaching Hospital, where she's a consultant surgeon, and she's also a lecturer at the University of Ghana Medical School. So join me in welcoming Dr. Lily Wu, who will take us through our first lecture for today. Dr. Wu.
Thank you so very much, Dr. Mable. He taught me too. And thank you to the organizers for the kind invitation. All right, so today we're going to talk about peripheral artery disease because much as we are at a cardiologist conference, peripheral artery disease is related to coronary artery disease in many ways than one. So for that reason, the two must be considered, because when it comes to management of the patient, it's more holistic. We don't only, from where I sit, save the limb, we save the life as well. So a brief definition says that peripheral artery disease is occlusive disease of peripheral arteries, and this is in relation to the limbs, both upper and lower limbs, even though majority of the time the disease is in the lower limb. And this leads to end organ ischemia. It may be acute, it may be chronic. From the community perspective or clinical perspective, we say somebody has peripheral artery disease when the ABI is less than 0.9. There is a caveat, because you could have a patient, especially if it's diabetic or chronic kidney disease, with an ABI of say 1.9, and you still will diagnose them of peripheral artery disease. But time will not allow us to dissect it to that point. If it comes to question time, we can discuss that. So the point has to be made that peripheral artery disease usually coexists with disease in other vascular beds. And the ones we are particularly interested in is cerebral vascular disease and coronary artery disease. And it's been proven beyond doubt that a low ABI is a surrogate marker for cardiovascular events and for cardiovascular death. Prevalence of peripheral artery disease using European data shows that it's the disease of the elderly. But we have had the privilege of doing some work among Africans, and we've realized that in the African population, the age mostly affected is about a decade younger than the European population. Again, it's been proven that as you grow older, the prevalence increases. So that, again, using European data, by the time you cross 70 and going, your prevalence doubles up. And in the European data, again, the male to female ratio is about 3:1. But in that African population we studied, it turned out that the incidence is actually 1:1. There are many causes of peripheral artery disease, but as you may have discussed yesterday, predominantly it is caused by atherosclerosis. And I'm sure your presenters have given you some education on that, but we'll give you a little summary today as well. Again, in the European data, smoking is the predominant risk factor. Again, in our studied population, diabetes was the leading risk factor. A little on the natural history of peripheral artery disease, because this informs the decision we take when it comes to management of the patient. And here we'll say that even though we are overwhelmed in the clinics with symptoms of peripheral artery disease, put together, the population of patients we see in clinic is just the tip of the iceberg. Just 15% of people affected with this disease. So you have a whooping 85% at home for various reasons, which time again will not allow us to discuss, who will not come to clinic. All right. But it must be said that whether the patient is symptomatic or asymptomatic, disease progression and the risk of cardiovascular mortality is the same. The other thing to mention is that of this little 15% of symptomatic patients we see in clinic, most of them will come with claudication, pain in the leg, worse with walking, relief when rested, walk again, pain comes. A whole lot of them, that's their pain. And we'll show a slide that will show you some differentials of this leg pain. And out of this, only 1% will progress to limb-threatening stage. Only 1%. So remember that in the clinical setting, we are treating just a little minute fraction of the disease burden in the community. This slide has been thrown in just to revise the anatomy, because this is also important when it comes to clinical classification of disease. And again, it informs our decision in terms of management. This is very important, foot arches, because when we talk about revascularization, we must go all the way, even beyond the point of occlusion, to interrogate how much flow patient has in the foot. Without that, anything you do is not fruitful, and you may not win. So a little summary on atherosclerosis. Unfortunately, I wasn't here yesterday because I was on duty. But atherosclerosis is a dynamic process. It's an inflammatory disease. So it starts off with some endothelial dysfunction, which attracts inflammatory cells into the subendothelial space. Of mention or of importance are monocytes. Once they arrive there, they easily engulf oxidized LDL. That's where the cholesterol thing comes in. And then we change name and call them foam cells. There's also activation of smooth muscle cells and other inflammatory cells in this space. And this inflammatory process or collection of inflammatory elements is what we call atherosclerosis. We said that it's dynamic. So it may well regress, but most of the time it progresses to the point of encroaching on the patency of the lumen of the vessel. That by itself takes many years and is not a threat as such. But what could happen to this plaque is that it could ulcerate as part of the process. And once it ulcerates, the surface that is exposed to circulation is very thrombogenic. So patients will end up forming a clot on the plaque, and that one is dangerous because primarily that clot can acutely occlude the vessel where the clot is formed, or that clot can get dislodged along the stream and then occlude distally and convert that chronic situation into an acute one. So we showed the anatomy a while ago because in clinic, we have to make a decision which pulses are present, which pulses are absent to clinically classify patients. So if a patient doesn't have femoral pulse, the inference is that the occlusive disease is either in the aorta, infrarenal aorta, or iliac, for which reason we'll call it aortoiliac disease. If on another occasion, patient has femoral pulse, but no popliteal pulse, remember when we are checking popliteal pulse, we are checking it behind the knee, but there is a part of the popliteal artery actually just above the knee, beyond the adductor magnus, which is adductor hiatus, which is an opening in the adductor magnus. So if you do not feel popliteal pulse, but femoral pulse is present, it notice that it could be that the obstruction is somewhere along the superficial femoral artery or this little first part of the popliteal artery. So we call that a FEMPOP, femoral popliteal disease. If on another occasion you have femoral pulse, popliteal pulse present, but no foot pulses, that is dorsalis pedis and posterior tibial, then it may be that the occlusive disease is either in the anterior tibial, posterior tibial, or the peroneal artery, for which reason we call it tibioperoneal disease. So in clinic, we have aortoiliac, FEMPOP, and then TP disease. And this is also important. In that population we studied, considering that the predominant risk factor is diabetes, they tend to have a classical picture of peripheral artery disease, where the disease tends to be infrapopliteal. It tends to be a long segment involvement, and the vessels are so calcified from beginning to end. And that's what makes revascularization difficult in the diabetic. Coupled with this, their chances of collateralization is also poor, and that is why their risk of losing a limb when they have peripheral artery disease is so high. On occasion where you cannot feel both femoral pulses, then it means nothing goes through the external and the internal iliacs, for which reason if they are male, not only will they have buttock claudication, but they may have erectile dysfunction. And we call that, forgive me, we call that the a little humor. It's not only in the sing-a-thon that you can lose your voice. Anyway. My pointer has given up on me. Pointer is not working. Somebody help me. Right. So we've made this point earlier on already about the burden of disease and the proportion that are symptomatic and the rest of it. So we'll not spend too much time here. Projector still? Okay. So this is the list of differentials that one must consider once a patient complains about leg pain. And in the vascular world, venous claudication is one of them. Much as both diseases occur when patients walk, the distinction is that with venous disease, you don't need to walk. You just have to put your leg in a dependent position, like standing for a long time or even sitting for a long time, which distinguishes it from peripheral artery disease. Because peripheral artery disease, you must necessarily walk the group of muscles distal to the point of obstruction to experience the claudication. Again, in venous claudication, patient will realize that sometimes it's associated with swelling, which is not too typical of arterial disease. And over and above that, they also notice that at the end of the day, when they recline or they are in bed, the pain gets better. Or even during the day when they raise their legs, the pain gets better. And that is counterintuitive to arterial disease, because if you have arterial disease and you raise your leg, it makes it worse. Again, we must remember spinal stenosis, radiculopathies, and the rest of it, because our population, much as we said in the African population we studied, are younger. They are pretty older too, so that they also are prone to having lumbar spondylosis, spinal canal stenosis, and all of that. So anytime a patient comes with lower limb pain, we take our time and ask detailed questions to tell that this is arterial disease. And on some occasions, we have to send them off to the neurosurgeons because it's not arterial disease, it's rather nervous disease. There are classifications to help you decide which limb you are likely to save and which one you are not likely to save. There is the older Fontaine classification and a more modern Rutherford classification. Grossly and in clinical setting, Rutherford 1, 2, and 3 are various degrees of claudication. By the time you get to Rutherford 4, you're talking rest pain. 5 is minimal tissue loss, and 6 is bigger tissue loss or major tissue loss. What do we mean? That when we say minor tissue loss, we're talking about a little toe ulcer or gangrene, or a little ulcer on the heel or gangrenous patch. But when you progress to Rutherford 6, then the whole foot is involved. In other words, as vascular surgeons, we are more likely to save the foot of somebody with Rutherford 5 disease than a Rutherford 6 disease. Putting Rutherford 5, 6, and 4 together, we call that chronic limb-threatening ischemia. It used to be called critical limb ischemia, but nomenclature has changed. Now we say chronic limb-threatening ischemia. And that distinguishes them from the claudicants, because soon we'll realize that when it comes to management, we are less aggressive with the claudicant than we are with the one with the threatened limb, because the outlooks are very different. Even with the acute setting, we also have a Rutherford classification. All of this is to help us know what to do and how fast to do it. So if you have somebody with an acute limb condition, pain, cold, pulseless, the thing is there arterial signal? Is there venous signal? Once there's arterial signal, there's venous signal, no motor fallout, sensation is intact. That's a Rutherford 1. That's a very viable limb. You have all the time to do whatever investigations you have to do. If you have a patient with no arterial signal, no venous signal, motor function is gone, no sensation, that's a Rutherford 3. You have to counsel them for ablation. The tricky ones are Rutherford 2, so that if you have the marginally threatened limb, which is 2A, they have just minimal sensory loss, but motor is basically intact. And there again, you can say, go do CT scan and come. But when you get to Rutherford 2, that is immediate threat. Sensation will be gone, and motor will begin to kick in. That you don't have the leisure or the luxury of sending to CT scan, and from where I work, usually outside of our confines, to come back. You will be, by the time patient comes back, they would have progressed to Rutherford 3. So that patient needs an on-table angiogram, a digital subtraction angiogram, for you to make a decision on the spot and carry on with management. I threw this in just to let us be aware that in the vascular world, we don't write prose when we say do an arterial scan for us. For those of us among the gathering who are radiologists, there are templates, and we are happy to share, so that in a split second, we can tell that this patient has occlusive disease in the superficial femoral artery, popliteal, and even below on the left side, but on the right side, it's only in the posterior tibia. And then it tells you the degree of stenosis and the various velocities. So if you're a radiologist here, please, we can share template with you, and don't write us prose. We don't want to read prose. We want to see pictures, because in vascular we say pictures paint 1,000 words. You could also progress to do CT scan and MRI, but we have made the point earlier on that when it comes to foot arches, CT and MRI are not the best of the options. So if you do digital subtraction angiogram, you see this person has reasonable dorsalis pedis, posterior tibia, but the arch is incomplete, and we cannot see a single digital artery coming off the arch. As opposed to this person, deficient dorsalis pedis, but a very strong posterior tibia, that gives us some digital arteries. You can only do this by threading your wires and your catheter down that circulation and do the injection into the circulation. You can't do it from peripheral vein in a CT. Very important. All right, so why do we even treat them? We treat them because we have made the point earlier on today that whether they are symptomatic or asymptomatic, what kills them is coronary artery disease. So the peripheral artery disease is the tip of the iceberg. Remember, there are arteries in the brain, arteries in the heart. And this has been proven, especially coronary artery disease, to form about 70% mortality among patients with peripheral artery disease. So when we are treating them, we are mindful of this, and we are not so engrossed with just saving the limb, we save the life. Okay, so what are the things we consider? We consider, like I have said this morning already, that since given 1 year, only 1% of claudicants will move on to have threatened limb, we will do medical therapy. Because in the surgical world, everything we do, no matter how innocuous it may seem, have complications. So for somebody who has very low risk, it's a risk-benefit analysis. So for somebody who has very low risk of losing the limb, why do you want to take him to theater, subject them to anesthesia with complications, even your surgery with complications? So we do basically medical therapy, lifestyle modification for the claudicant because their outlook is very good. Give them even 5 years. Out of 10 patients, less than 5 will move on to threatened limb in 5 years. But if you take them to theater and do something today and you embolize an atheroma, they get acute limb right there on you and you may lose the limb that day. When given 5 years, they may not lose a limb. So we are less aggressive with the claudicant. On the other hand, with a threatened limb patient, give them 6 months. Half of them will lose their limb. 2 out of 10 will die. So therefore, we are more aggressive, and they are the people we offer surgery. So before we offer you surgery, like I keep saying, we manage you holistically. Lifestyle modification. So if you're a smoker, we help you to stop smoking. Get psychological consult, get some medications to help you cope without the nicotine. And if you're hypertensive, diabetic, with high cholesterol, we try and manage that as well. So you realize that it's not just the vascular surgeon, but it's teamwork. And we send patients over to the cardiologist all the time, and we consult the cardiologist as well. When it comes to lifestyle modification, if you are sedentary, we try to get you to exercise. And it's been proven from literature that supervised exercise is more effective than leaving the patients on their own. All of this help to prevent disease progression, relieve symptoms, and avoid cardiovascular events in the future. So we talked about the multidisciplinary approach to patient management. So when it comes to pharmacological treatment, we give patients antiplatelets. And using the COMPASS trial, it's been proven that anticoagulant alone or antiplatelet alone is not as effective as when the two are combined. Before COMPASS trial, we were doing antiplatelets. We were not even doing anticoagulants. But the current evidence shows that when you combine anticoagulant with antiplatelet, the outlook is brighter. And this is a randomized controlled trial of over 30,000 patients, so it is credible. We also give them statins. Statins have plethora of benefits. It's not just about dropping your cholesterol level. In fact, it's been proven to have some antiplatelet effects and anti-inflammatory effects as well. I'm sure we learned that yesterday. So in summary, peripheral artery disease is a marker of generalized atherosclerotic disease, all right? And that lowering your cholesterol level goes a long way of preventing disease progression. And that the current recommendation is to by all means give patients statins, even if their baseline cholesterol level is normal. It's been proven that giving them statins still helps. So when it comes to revascularization, we look at the patient. How old is the patient? What are the patient comorbidities? What is the life expectancy of the patient? What is the level of disease? Is it aortoiliac? Is it FEMPOP? Is it tibioperoneal disease? The interventions we have, what is the longevity? Are we doing endovascular or we're doing open surgery? What are the risks and what are the benefits? And when it comes to deciding whether to do minimally invasive endovascular procedure or open surgery, using the task classification helps. Again, we don't have time, but this is just to tell us what the task classification is. So when it comes to open surgery, one of the things we could do, especially if it's a big vessel like the femoral, is to open onto the vessel. And the beauty about vascular is that much as we are saying open surgery, if it's a localized disease in the femoral, we can do it under local anesthesia, which is much safer, much, much safer. So local anesthesia with some sedation, we crack on. Give the patient a cut down, open onto that vessel, and take the atheroma out. So you do an atherectomy, and then you patch it. You will not close it primarily, because if you do, you cause stenosis. If that is not possible, like if it's the occlusive disease is in the superficial artery, then you have the option to do a bypass. In doing a bypass, you must scan the patient's veins, great saphenous vein or cephalic veins. And by all means, if it's possible, use the veins, because recurrence with vein is less, occlusion of the vein is less. On occasion where you can't get native vein, then you have to use prosthetics. When it comes to bypass, we can also do it anatomically or extra anatomically. So this one is an atherectomy we did. Not peripheral disease, this is carotid actually. So this is the internal carotid. The external carotid is somewhere here. And this is a bovine patch. Though this is the atheroma we scooped out, you can see the rough surface. I think by this time we have taken the clot off it. This is a patient who has suffered a minor stroke. So here is an anatomical bypass. By the time we met this man, and he's one of the high-profile persons in town, he had lost the right limb already. And he was on his way of losing this left. But this man had an angiogram. And when we went beyond this occlusion, we realized that there's something reasonable in the foot. He has reasonable posterior tibial, anterior tibial. We thought this man, we can win with a bypass. So we did a FemPop bypass, bypassing the obstruction. And this has been going for 5 years now. He's still walking. He can't thank me enough. And the wife especially. Because it's difficult nursing a man without both legs. This one is an Italian. He is a chain smoker. Came with this minimal tissue loss, Rutherford 5. He has aortoiliac disease. There's a big cutoff here. What you see here is just a leash of collaterals. Again, we operated on him under local anesthesia, gave him cut down here, cut down there. Using these collaterals, he was able to reconstitute the left side reasonably well. So femoral pulse here was strong, this was weak. So we gave him an extra anatomical bypass. In other words, there's no natural traversing one limb to the other in this direction. So when we say extra anatomical, it means it's outside of the normal anatomy. So we gave him a left to right fem-fem crossover. And as you can see, his wounds healed. All right? When it comes to the endovascular treatment, the old one is a plain balloon, no drugs added. But it's been proven that that doesn't give you very long-term outcome. So you have all these balloons that you manually put in the area of stenosis and dilate the area. In other words, you do angioplasty. But going forward, there are balloons now that are drug-coated. They are coated with chemotherapy to kill the endothelial cells that otherwise will proliferate later on and cause restenosis. Then came stents. So in occlusive disease, we use bare metal stents, but in aneurysmal disease, we use covered stent. Because if you use plain bare metal stent in aneurysmal disease, the blood flow will just get out. So in aneurysmal disease, we use covered stents. I just threw this one in to show some of us who may not have the benefit of seeing stents. Having said all of this, there are occasions that we still lose a part of the limb. And I tell my trainees that in the vascular world, the anatomy may not look pleasant, but we are more obsessed with functionality. If you can walk with a third of your foot, it's better in the night to wake up to the washroom than wake up and look for a leg to wear before you can move. So there are times that we sacrifice some toes. There are times that we sacrifice a third, half, even 2/3 of the foot. And this picture is to show us some of those ones. They heal and they are able to step on these stumps and they are independently mobile. That's our aim, without giving them a below knee or an above knee. And having said that, this default of giving people above knee must stop, because we have learned over time that in atherosclerotic disease, usually the profunda femoral is spared. So if blindly you offer them above knee, you are likely to heal the wound. So people, once you come with any tissue loss of a toe, above knee. And we have seen so many people who were offered above knee, and we have been able to save their foot. Please. This one, he's still around, lost all 4 toes. This wound eventually healed. When he's wearing his boots, you wouldn't know he has lost some toes. And he's independently mobile. That is our aim. But you wouldn't think that this anatomy is pleasant. But instead of this, he was going to get, as usual, an above knee. This one also has aortoiliac disease. This image is rotated, so we are looking at him posterior anteriorly. So this is actually his right side, and this is the left side. High-grade stenosis here. Infrarenal aorta is shaggy, very, very diseased. But this was a 79-year-old man. And that reminds me, this man had had triple coronary bypass before. And it's one of the struggles I have practicing vascular surgery, that many times somebody says, leave them alone, they will die. And I said, if you leave them alone, it's a one-way street, they will die. But in vascular surgery, we give them a chance, no matter how slim that chance is, because you can win with some. This man has had triple bypass. He was 79. He has a whole bag full of medication. We offer them a hybrid procedure, part endovascular, part open. In other words, even though his vessel is so diseased, we stented this side. So that's what you are seeing in this schematic. We stented this side to divert the flow all the way into this left side. We plugged this because there is a little opening that can flood our stent. And again, we gave him a fem-fem crossover. This man has made it beyond 80 years. Again, he can't thank me enough. And I always tell the story, he's an illiterate. So he comes with his little brother who is literate and helps him with his medications. And each time they come and the little brother is trying to give me up, they say, oh, Nyamicha, yakom, oh, ya doctor, Anna. Yakom na doctor, kasa doctor, wadaruma kasa. You know, he's so grateful. He's made it beyond. But he could have died under my hands, nevertheless. But if I had left him back then, this man couldn't walk. He couldn't even stand up. When I met another friend of his, he said, doctor, do you know why you're madam for no? Say, so an auntie is a soldier. You know. So vascular surgery, we take our chances. Because if you leave them, it's a one-way street, they will die. All right. That's modern technology. Instead of shoving in stents and doing angioplastics that can rupture the vessel and you can embolize and atheroma, now you can actually go and scoop out the atheroma with a atherectomy device that sucks it at the same time. So the risk of emboli is less. Okay, in conclusion, OMT stands for optimal medical therapy, plus supervised exercise, endovascular treatment or open surgery, slows down disease progression, relieves patients of their symptoms, and ultimately prevent cardiovascular events and mortality. Thank you.
Thank you very much, Dr. Wu, for that most interesting presentation. I'm sure there may be a few questions, and for our online audience, you can enter your questions in the chat box. Do we have any questions from the floor or from our online participants.
Thanks for that excellent presentation. Just a quick one. Do we actually have any atherectomy devices in the country?
We don't have it yet, Professor. We're waiting for you to bring us one.
Okay, Dr. Doku. Thank you very much for the presentation. You mentioned that most of these patients would die from myocardial infarction or a stroke. And for a man who has peripheral artery disease with erectile dysfunction, yes, he would die 10 years later. But that 10 years, you know, he probably would say, look, I was dead 10 years. Today I'm dying today, but I died 10 years ago. And that's what the wife would also say. So I want to find out how many of these patients have you gone further to assess for erectile dysfunction, looked at the pudendal arteries. How many of these pudendal arteries have you been able to work on in your experience? The second question has to do with diabetic foot. We see these cases a lot in our emergency room. The surgeon will say, control the sugar, and they will work on the foot. And then the physician said, no, because the foot is festering with this infection, we can't get the sugar down. And it's been back and forth. The smell in the emergency room is really something that nobody wants. I think we need to do something about it. It's still a problem. And as you said, above foot amputation, and then the problem is solved to some extent. But I think we need to do more to save these, feet. So I want to know your experience. What capacity are you building in Ghana, to save the diabetic foot? For some, you're doing partial amputation, but the problem is big, probably beyond you. So what national capacity are you building? So the first one has to do with the pudendal artery. How many are you doing to save the men who probably would die 10 years later, but in actual fact, they died 10 years earlier. And then the capacity to save the diabetic foot. Thank you.
Thank you, Dr. Doku. So we typically don't go looking out for pudendal, even when clinically patient says we are dysfunctional in that aspect of our lives. Erectile dysfunction, all right. So especially with the ato-iliacs, they typically will have some erectile dysfunction. That we work with the physicians and we do medical therapy, because at this point, doing any endovascular intervention there doesn't help very much. If the occlusion is in the common iliac and you stent the common iliac, you improve flow into the internal, and that may improve their erectile dysfunction. But usually it comes all the way across the bifurcation. So then you have to, as it were, give them a bifurcate stent, which is quite tedious to do with attendance risk. Because remember that your pudendal is not only heading to the penis, but also to bowel. If you cause bowel necrosis, big problem. So it's, again, risk-benefit analysis. If you can take some Viagra and function, we think that is safer than getting you a colostomy. All right. Capacity building, work in progress. It's not easy, especially there is no national plan or even institutional plan in terms of training. Trying to woo people, but it's also not easy because you can't get posts elsewhere, but most of those posts that are paying is an observation. At best, they'll take you to some laboratory to use dummies. But when you get hands-on, unfortunately, it's a non-paying. I have survived that 3 years. How many of us will take that option? We'd rather go to Britain or America and observe and get paid. You don't want to go to India or China where you don't get paid, but you get hands-on. So we'll get there. It's work in progress. Thank you.
Any other questions? All right, so we have no questions in the chat box. That brings us to the end of this session. Thank you very much, Dr. Wu, for a very interesting presentation. Our next presentation will be a pharma presentation. So if we have the representative of one pharma here, please come up and give us your presentation. So just a little pause while we get our presenters on board. All right, so we have the representative for Denk Pharma here. So they'll give us their presentation.
Hello. Good morning. My name is Ebenezer Edunyako. I'm a pharmacist from Denk Pharma. Okay. So we say Denk Pharma is a trusted partner in cardio health. This morning we want to briefly discuss a topic with caption, Getting the Numbers Right, the Role of Fixed Dose Combinations. Some report from the WHO stated that about 1.3 billion people are living with hypertension worldwide. 1 in 3 adults also affected worldwide. And then very interesting is the fact that 4 out of 5 of these people, the report says, are inadequately treated. So we want to find out why. So these are the effects of the uncontrolled blood pressures, and this is what most clinicians and patients alike will not want to experience when they have hypertension. So research conducted in Ghana by 3 researchers showed that patients who are uncontrolled on their medication, about 69.7% is due to the fact that they are on monotherapy. About 43% is because they are not compliant with their medicines. And then, of course, issue of access contributed to about 58% of uncontrolled hypertension in Ghana. The ESC and then the ESH also looked into the reasons why the patients are uncontrolled, even though they may be on treatment. And on monotherapy, they found the reason for it as being insufficient use of combination therapies. And this they attributed to treatment inertia. The fact that most clinicians or patients don't want their medication changed or added on. For compliance, they realized that it is due to pill burden, the fact that patients are taking a lot of medications, and then the side effects associated with them. And then, of course, the complexities of multi-drug treatment, where they are giving individual molecules to take. So that complexity makes them non-compliant. So on access, the ESC also attributed it to the high cost of the most effective medicines, and then also the unavailability of cost-effective combinations. So then, having realized these issues, we also wanted to prefer a solution. So in controlling the blood pressure, what is the solution Deng Pharma is offering? Deng Pharma on access is offering consistent availability of our most trusted products. We have been in existence in Ghana for over 30 years and above, and we've been in existence since its inception for over 75 years. So it means that we are very consistent with the quality products that we give to our clients and patients. And then we also ensure that we are giving effective fixed dose combinations to take care of access to fixed dose combinations. And of course, we are also a trusted generic company giving you cost-effective products. On the issue of compliance and its associated monotherapy, Deng is offering 3 amazing products to our clients and then to patients alike. So we are offering Amvadeng, Perinam Deng, and then Kolosa Deng. So first is Amvadeng. Amvadeng is a combination of amlodipine and valsartan. We have 580, 5160, and 10160 dosing ranges. So of course an area will be valsartan and then amlodipine. What does Amvadeng offer the patient? So of course Amvadeng, the combination is highly recommended by major guidelines, and it's a very potent combination. It helps with compliance because it's a fixed dose combination therapy, and it's effective in delaying the progression of diabetic and non-diabetic CKDs. The next product we offer is Perinam. Perinam is a combination of perindopro amlodipine, also a fixed dose combination, very effective in the management of hypertension. What it does is we present the tert-butyl salt of perindopro, which is equivalent to the arginine salt of the innovator Coberam. So it is different salt, but of course the same effect. It's significantly more effective in reducing blood pressure than when the individual molecules are used separately. And it's also a potent combination that lowers important cardiovascular events and reduces total mortality and risk in hypertension patients. So Perinam, perindopro, amlodipine. So the last combination, fixed dose combination we offer is an ARB, which is losartan, very known ARB, in combination with the diuretic. Most patients are taking the molecules separately. Deng is offering a fixed dose combination of losartan and hydrochlorothiazide, makes it compliant and easier. So of course, it's convenient for patients who are currently taking the 2 molecules separately. Helps improve compliance and safety because you are sure that your patient is getting it from a reliable source. And then cost-effective fixed dose combination for the general population. And then also helps achieve better control than monotherapy. So in conclusion, we say that When you prescribe Amvadenk, Perinamdenk, or Colozadenk, what you are prescribing is, of course, a high-quality product from a trusted company for your clients, products with regular and consistent availability, cost-effective products, well-tolerated combinations for long-term treatment, products with reduced pill burden due to, of course, the single pill, and then products that are effective in helping reach BP goal for your clients. Thank you.
Thank you very much for that presentation. Good. So I'd like to thank our presenters for this morning's session. I'm happy to say that we've gone according to time, right on schedule. So at this point, we'll take a 15-minute coffee break. I believe it's at the same location, right? So we can go out now and reassemble in 15 minutes to continue. Thank you for being such a good audience. Welcome back from the break. I'm sure you'll agree everything's going well so far. We have finished the first section of this AGM. There's just one more presentation left, and that's on imaging, which will be brought to us by Dr. Fafa Maku, and he's going to present online. Dr. Maku trained here in Ghana at the Kolebu Teaching Hospital, where he got his fellowship in internal medicine. He then went out to the United States to specialize in cardiology and settled there. He's board certified in several disciplines related to imaging, MRI, echocardiography, and he runs an imaging center at Bridgeport Hospital, which is attached to Yale University. So he is a director of the Adult Cardiovascular MRI unit at Cruz Hospital in Syracuse, New York. So he's now going to bring us a presentation on imaging in atherosclerotic cardiovascular disease. Let's welcome him on screen.
Good morning. Can you hear me?
Yes, we can.
All right. Thank you very much. Yeah. Thank you, Dr. Amable, for those kind words. And good morning, everyone. It's just about 4:30 a.m. Central Time in the US here. So forgive me if I sound like I'm just waking up, but hopefully we'll have a good half an hour talking about imaging in atherosclerotic cardiovascular disease. I would like to thank the executives of the Ghanaian Society of Cardiology, as well as the organizing committee for this honor of inviting me to present on at this annual general scientific meeting. So not to waste any time, in the next half an hour, we'll try to discuss the various modalities for detecting subclinical as well as clinical ASCVD. We'll also go briefly into determining the pretest probability and clinical likelihood of coronary artery disease. I'm going to try to focus a little more on coronary artery disease. I know it's the big topic of atherosclerotic cardiovascular disease, but my good friend, Dr. Wu, has just given an excellent lecture on peripheral arterial disease. So I'm going to focus my attention mainly on looking at coronary artery disease, which is what we do the bulk of imaging in when it comes to looking at the ASCVD. And then we'll try to finish off with trying to choose the appropriate test for evaluating patients presenting with chest discomfort. So basically, we'll go through some brief introduction, look at some modalities, and finish off with looking at the tests that we can use to diagnose obstructive CAD in patients who present with chest pain. So as you already know, yeah, we've made a lot of advances in cardiovascular care, and that has resulted in a decline in mortality, especially in the advanced countries where acute heart attacks are treated emergently with primary PCI. But cardiovascular disease still represents the leading cause of death and mortality worldwide. And though age-specific mortality has declined. We still see increasing prevalence or increasing morbidity due to increasing prevalence of risk factors as well as an aging population. So, for example, in my clinic, a lot of my patients are 80-year-olds, and every now and then I see a few patients in their 90s. So just with the aging population, we see increased morbidity of cardiovascular disease. All right. When you come to Africa south of the Sahara, according to the WHO, the past quarter of a century, the prevalence of cardiovascular disease has increased almost by 30%. So where imaging comes in is it plays an essential role in terms of diagnosing, risk stratification, and also making decisions about treating the patients, as well as trying to improve outcomes, in which case basically what we try to do is to reduce deaths and make people live longer with their cardiovascular disease, but also make them feel better. And imaging plays a critical role when it comes to that. So the good news in the field of imaging is that we have several tools in our armamentarium for evaluating patients. So that comes with challenges in terms of when to use one particular tool and what is the appropriate patient. Okay, I think I'm having some problem with some of my images, but that's okay. So this was just basically to show us some of the various imaging modalities that we have in evaluating for atherosclerotic cardiovascular disease. So this is just a little funny cartoon which try to poke fun at nuclear medicine. That is probably the less sensitive part of our imaging portfolio, but that is actually not true in a sense. But this was just I read all these modalities, so I guess I can get away with poking a little fun at nuclear medicine. So this is just nuclear medicine and ultrasound, which will mostly in cardiology will be echocardiography, cardiac CT, and then cardiac MRI. So let's talk about the various. So exercise ECG testing is not, in a strict sense, an imaging modality, but it's the most commonly used test in evaluating for obstructive coronary artery disease. And why? Because it's widely available and accessible. You really don't need any requirements to obtain IV access, and no radiation exposure, relatively inexpensive if you compare it to the other imaging modalities that I'll be talking about. And not only that, it's been extensively evaluated in terms of its sensitivity, specificity, and also prognostic information that we get from the study. So this just, so basically you monitor somebody, you put somebody on the treadmill and you have them hooked on with EKG leads, which you monitor in real time, and also check their blood pressure at the periodic intervals. So that's what the test involves. And these are there are different protocols that we use, and they are normally controlled by the computer, who then goes through various stages of this exercise protocol to whilst we watch them closely for signs of chest pain, whether they're having any ECG changes, and their blood pressure response to exercise. And we can also pick up any significant arrhythmias that may be occurring during the study. As good as a test it is, it's not feasible for patients who are unable to exercise to an adequate level, especially in the Western Cape. We are dealing with a lot of older folks. They cannot exercise, so in that case, you cannot do an exercise ECG test. And there are also patients who because of baseline ECG abnormalities. Unfortunately, the study will be non-diagnostic. And these are some of the conditions or ECG abnormalities for which an exercise stress test will not be feasible. So you talked about left bundle branch block, ventricular pace rhythm. If they have left ventricular hypertrophy with significant repolarization abnormalities, resting ST segment depressions that are more than a millimeter, and if you also have Wolff-Parkinson-White syndrome with ventricular pre-excitation on the ECG. Then we come to ultrasound or echocardiography. In the true sense of an imaging studies, is the most available imaging modality. And it's also the most cost-effective, and it just does that. It gives you both anatomic information as well as physiological data, which is difficult to get in some of the other imaging modalities we use. So it's actually a very great tool and in evaluating patients for atherosclerotic disease and more specifically coronary artery disease. So this is from the 2019 European Society of Cardiology guideline in terms of evaluating patients who come in with angina or an anginal equivalent, in which case could be dyspnea. And it's basically says that resting transthoracic echocardiogram is recommended in all patients for exclusion of alternative causes of anginas, because not everybody presenting. Sometimes it could just be heart failure that is presenting as myocardial ischemia. And one of the things we could do is to assess left ventricular function and also look at whether there are any regional wall motion abnormalities that will indicate the presence of coronary artery disease. And then you could look at other things. Is there pericardial effusion that could suggest that maybe this presentation is more due to a pericarditis rather than an acute coronary syndrome. So not just the resting echocardiogram, you could also do stress echocardiography, and you could do exercise, which is the preferred if somebody can exercise. You do the same thing as you do with the stress ECG, but you take pre and post exercise images. If people are unable to exercise, you could do a pharmacologic study, and we usually use dobutamine. It's convenient compared to the other imaging modalities. It's fairly short time for the study, and compared to, let's say, radionuclide myocardial perfusion imaging study that could take maybe 3 to 4 hours to complete. And also, again, no radiation exposure. And again, you get additional information. You could get information on the aorta. Could it be an acute aortic syndrome that's presenting as an acute coronary syndrome, presenting with chest pain or angina? And it's also more readily available compared to the setup that you need to do a stress echocardiogram is much easier compared to if you had to start a radionuclide myocardial perfusion imaging program. So the next modality, which I already mentioned earlier, is the radionuclide myocardial perfusion imaging study, or that's where we look at nuclear cardiology. It's another way to look at it. And there are two different types that we run. There's the SPECT, which is more commonly used, and also there's the PET. The SPECT is the single photon emission computerized tomography. The PET is a positron emission tomography. You could do an exercise test, which is again the preferred modality because you get physiologic information, and then you also get exercise tolerance, which gives us very good prognostic information. But for patients who cannot exercise, you have the option of doing a pharmacology study. And after you, so you do both rest and stress images, so that you could compare the difference. And this is how it's outlined when it's displayed for us to read. But basically, after you inject them the radio tracer, they'll go into the scanner where we obtain the images, and then these are processed and we generate the images for review and for diagnosis of CAD. So the myocardial perfusion image studies, they've got good sensitivity and specificity. They've got robust prognostic information because they've been used over a long period of time, especially the SPECT. And you could also use them when it comes to myocardial viability, which is the concept of if somebody has coronary artery disease. We don't do this routinely, but every now and then, especially when people have to have high-risk surgery or high-risk percutaneous intervention, and you're asking yourself, is it really worth it? We sometimes go in and then look at, is the myocardium viable? If we fix the stenosis, will this heart recover its function? And one of the modalities that we commonly use is a PET study, an FDG PET study, to look for myocardial viability. Of course, as I mentioned earlier, it's more costly, especially and then it comes with some radiation exposure. The cartoon that I showed, which was I said was spoken for nuclear cardiology, one of the downsides is we have a lot of what we call attenuation artifacts. So that sort of affects the specificity of the test. So we could see things that will appear as perfusion defects, suggesting either ischemia or myocardial infarction, but actually turns out that it's just an artifact. So that's one of the downsides of the MPI. And then we move on to cardiovascular magnetic resonance. So it's the non-invasive gold standard if you are looking at people, left ventricular mass, left ventricular volumes, and assessing systolic function. So now if you're doing trials looking at those, MRI will be cardiac MRI will be the way to go. And so it's just like any other MRI. You just have to get a software, and then it generates the spatial resolution is just great compared to all the imaging modalities. It's got the best spatial resolution, and it's not affected by patient body habitus. What I did mention, both for echo and for myocardial perfusion imaging study, we run into trouble in obese patients where that affects imaging quality. There are things that we do to improve that, but still, if you have a study that is not affected by patient's body habitus, then that is absolutely a welcome addition to the tools we can use in imaging patients. So that's one of its big advantages. And it's also very sensitive compared to an MPI for detecting myocardial infarction. Yeah, well, if you have a gram of infarcted myocardium, you certainly can pick this up with a cardiac MRI compared to myocardial perfusion imaging study. Again, it's one of the modalities that we use for myocardial viability. Because it's good at detecting infarction, we look at how of the muscle in terms of what percentage of the muscle wall is infarcted, and that helps us in deciding whether we think the myocardium is viable or not. Yeah, the limitation of the CMR is that it's not widely available. With MRIs are available, but getting the software and expertise is not. And when it comes to using MRI for perfusion imaging. You cannot do an exercise portion at this time. There's still work to try to see whether they can get in. So it's the only modality for, or the only option for ischemia evaluation, I should say, is really just pharmacologic. And then the next modality that will be a cardiovascular computed tomography, which is cardiac CT, and is the most sensitive test for detecting a coronary artery disease, and it's really got an excellent negative predictive value, and that's one of its core strengths. Is if you do a cardiac CT and a person has no plaque and no stenosis, their prognosis is just over the next 5 to 10 years is great. So basically, same CT scanner, you just have to get a cardiac software, and then we could display the images either as two-dimensional images, which is how we read them, but it also gives you nice 3D images, which you could look at, and helpful in some circumstances, like if you're trying to look at anomalous coronary arteries, 3D images become very helpful. So in terms of the modality we have for diagnosing obstructive CAD, CCTA is the modality of choice to really exclude disease in low to intermediate risk patients with low to intermediate pretest probability for obstructive CAD. And the other thing, it's also very helpful for that. Even if you don't have obstructive coronary disease, you can detect plaque, which would then translate into change in their management in terms of prescribing statins and antiplatelets. And that has been shown in the Scott Hart trial that it leads to improved outcomes, because I will show you in the next slide a little more about that. And one of the other key strengths of coronary CT is it's very reliable in ruling out left main disease. And when it comes to coronary disease, the one lesion that we know definitely, if you intervene, improves, reduces mortality, is somebody with left main disease. So it's very critical. So in the ischemia trial, which was a trial looking at invasive versus medical management for people who had an abnormal stress test, what they did was all the patients had a coronary CT to make sure they didn't have left main disease before they were randomized to the medical arm, because you don't want to miss that. And that's one of the great things about using a coronary CT. And that was just the point I was making, that because we see non-obstructive plaque. So this slide is just showing a patient who came in, had a normal nuclear stress test, as you can see below here. But then when you look at the CT images, you could see non-obstructive plaque. And one of the plaque, though it's not obstructive, it's got high-risk features that could suggest an impending acute coronary syndrome. So you're able to pick that up, and it's not uncommon. I've had a good number of patients who have a normal perfusion imaging study, but still having a good story concerning for myocardial ischemia, and you send them for a CCT, and they may have an obstructive lesion that was missed by the functional testing. So its sensitivity, it's absolutely great, and that's why it's got that excellent negative predictive value. But even if you don't, because some people have a normal functional study, you do a cardiac CT. Yes, they don't have obstructive disease, but they do have a moderate atherosclerotic plaque burden, and that was going to translate into getting aggressive with lipid lowering treatment, as well as adding an antiplatelet. And the patients too, knowing that they do have some atherosclerotic plaque, are more likely to make some lifestyle changes to reduce their risk of cardiovascular events down the line. And then I will not just, I really want to focus on non-invasive testing, which is my area of expertise, but I'll just want to say that invasive coronary angiography, that's the gold standard. When we are comparing all these modalities in terms of their sensitivity and specificity, we are looking, the gold standard is invasive angiography. And if somebody has a significantly abnormal functional test or a coronary CT, we end up referring them for invasive coronary angiography to really determine how severe those lesions are and what will be the appropriate treatment, whether just continue medical management or they're going to need surgical or percutaneous revascularization. So what do we do when we want to screen asymptomatic patients for atherosclerotic disease? And we see this patient comes to you, he's got a strong family history of a premature CAD, and comes to see you for cardiac risk assessment. Or you have somebody who's, if you use, here in the US, we use what we call the pool cohort equation to assess based on some risk factors and their lipid panel. We look at what their 10-year risk of atherosclerotic cardiovascular event is. And those who sit in the intermediate range, sometimes they are reluctant to start cholesterol lowering medications, which most of the time will be a statin. You may use some sort of imaging to tip the scale, or use them as a tiebreaker to decide whether they're going to benefit from starting therapy, or whether you could just continue with lifestyle changes. And the calciums, so you can either use a coronary artery calcium scoring, or you could use an ultrasound. And this data that's showing that depending on how extensive coronary artery calcium score you have, or your atherosclerotic plaque burden, the higher your chances of having an incident cardiovascular event. If you look at this Kaplan-Meier curve, so and then looks, so the red is people who are the 90th percentile. You normally use this calculating using data from the multi-ethnic study of atherosclerosis, and you put these patients in, you could give them percentile in terms of their calcium score, and but then the higher it is, the more likely they are to suffer a cardiovascular event down the line. But even more important is what we call the power of zero. So somebody with a zero score, their mortality, if you follow them, and this was derived from almost 20,000 patients, looking at the overall mortality over a 10-year period. And people with a calcium score of zero, really their mortality is just about 1%. So that's how powerful a tool it is. And so, in fact, when people do chest imaging now, even for non-cardiac reasons, it's so critical to have them comment if they do see coronary artery calcification on the CT. And if I see any patient now, one of the things I would do will be to look there, see whether there's any evidence of coronary artery calcification. So that is absolutely very useful information when you are seeing a patient. Basically, just quick, this is about arterial ultrasonography. The American guidelines really have no place for the use of this, but it's in the European guidelines in terms of using this to either as based on what you see on ultrasonography, looking at the carotid or the iliofemoral region, using that to as a diagnosis of atherosclerotic disease, or using that as a sign of subclinical disease to change management. And it looks like from what we know, the plaque burden seems to be a better correlate than just the presence of plaque. Yeah. And I don't know whether you could see it, but this was just the European guidelines, which does have a role for using ultrasonography in management of patients who may have subclinical atherosclerosis. And I will quickly move on to the looking at the pretest probability of disease. And I'm just trying to give a best eye view, because each of these topics and each of the modalities themselves are several lectures by themselves. So basically, when you see a patient based on their age, sex, and the type of chest pain they are having, you could put them in either their low pretest probability, more intermediate pretest probability, or high pretest probability. Usually, you don't test people who are low pretest probability. Most our non-invasive testing is centered on people who have an intermediate pretest probability of disease. And then people are high risk, you'll make a determination whether you are going to do some sort of functional testing, or maybe, especially in the setting of an acute coronary syndrome, they'll probably be going in for an invasive coronary angiography. Though this model here is really for people with stable chest pain. So there are tables there in the guidelines in the American Association of, American Heart Association, American College of Cardiology, as well as the European Society of Cardiology guidelines. They have these tables in there. They do tend to estimate the pretest probability of CAD, and that leads sometimes to unnecessary testing. But they are still useful places to start with, and sort of gives you an idea, depending on which document, maybe 15 to 50% is considered intermediate, or sometimes 10 to 70%. So, but this is just another, this from the European guidelines where you're looking at. So the patients in the areas in the dark green are the ones, so they look at 15 to 50% are the ones who you should really be targeting your non-invasive functional test in terms of their pretest probability. This slide is from the American guidelines, so I'm just going to skip it, just along similar lines. But one of the things you want to do is to refine, not just go by the pretest probability, because that doesn't include a lot of risk factors, just the type of chest pain, the age, and the sex. So you want to refine that, and that's where we talk about the determinants of the clinical likelihood of coronary artery disease. So you're beginning to talk, do they have risk factors like smoking, diabetes, family history? Is their ECG abnormal? Do they have some LV systolic dysfunction or regional wall motion abnormalities? Or have I looked at their CT and they have a lot of calcium? So that begins to sway the pendulum one way or the other in terms of their likelihood of having coronary disease. And that will kind of may further re-stratify them, and then change the kind of testing you would like to pursue when it comes to trying to diagnose obstructive CAD. So in deciding what appropriate test is for evaluating patients who present with chest pain, and you're looking for, one is, can they exercise? If they can, then they are really a candidate for an exercise ECG test. But is their resting ECG, is it significantly abnormal? And that may be a reason not to do that. And then you look at why we're performing the test. Is this somebody who's already has no coronary artery disease? You're trying to rule out significant ischemia, in which case you definitely want to be using an imaging modality, a resting a stress ECG test cannot answer that question. And then you also look at the patient's body habitus, as I talked about. If they are obese, have some COPD, then a stress echocardiogram is probably not the way to go. You're either looking at maybe a CMR perfusion study or myocardial perfusion, an MPI study. And if they do have a history of prior coronary vascularization, then a coronary CT will also be will not be the right choice in that kind of scenario. And the other scenario too, where you want to avoid a coronary CT if there's extensive coronary artery calcification, that just really drops the specificity of the test, which is the problem we have with a coronary CT. All right, I don't know whether you can see this slide very well, but this is just looking at generally for patients with low to intermediate risk of pretest probability of disease or clinical likelihood. A coronary CT is a good place to start from, though, because of availability and an exercise stress test, if they can exercise, is absolutely also acceptable. And then when on the high end, the higher the risk, you will probably want to do an imaging study rather than just an exercise stress test. And we'll talk about that. It's just mainly related to the sensitivity and the specificity of this test. And then obviously, if they are very high risk, then you are probably looking at an invasive angiogram. Busy slide here from the ESC chest pain guideline from 2019. Basically just talking about some of the things we have alluded to earlier in terms of what is the clinical likelihood of disease and what tests you should be choosing. So low to intermediate risks, you probably will go for a coronary CT, or I would say an exercise stress test. The ESC doesn't really favor exercise stress tests without imaging, though you could do it. Yeah, the American guidelines do still say that if the person can exercise and their ECG is not abnormal, and exercise ECG test will still be your first line, but at least for people coming with stable disease, and then coronary CT. And sometimes we also use the coronary CT for people who have an equivocal stress test, or maybe mildly abnormal stress test. You don't think that they really need invasive angiography, and you just want to get a better sense in terms of anatomic imaging, which looks like carries more prognostic information than the amount of ischemia if you look at the ischemia trial. So this basically, if you do the different tests, the exercise ECG, your myocardial perfusion imaging study, which is your SPECT or PET, your stress echocardiography, your CMR, your coronary CT, or your invasive testing, there are certain criteria that will make these people high risk, for which you may want to either treat the lesion if you are doing an invasive coronary. Sorry about that. If you are doing an invasive coronary angiogram, or if you are doing a non-invasive test and you think that patient will benefit from further evaluation using an invasive study. So this is just looking at the the test performance of the various studies I mentioned. And this way it comes in. You could see just the sensitivity of an exercise ECG, 45 to 61%. That is very low. So sometimes up to half of the time, more than half of the time, you could be missing coronary disease if you use just an exercise ECG. The specificity here is 70 to 90. I say that's general, but especially for women, the specificity is much lower, where you could see up to a lot of false positive studies with abnormal ECGs, but no obstructive CAD. So that is the big downside of the exercise ECG: low sensitivity and also low specificity, especially in women. The other imaging modalities, echocardiography, exercise SPECT, pharmacology stress echo, and pharmacology SPECT, as well as CMR. They have similar sensitivity and specificity. Yeah, just slight differences here, but for all intents and purposes, they are considered very similar in that regard. So you, depending on the patient character, you could choose any of them. A coronary CT, where it separates itself really, is where you see sensitivity between 93 to 99%, especially now. So a lot of this data was when we have a 64 slide scanners. Now we have a lot more advanced equipment, so the sensitivity is probably closer to 99%. At least that's what I quote for my patients, that if I do a coronary CT, there's less than maybe a 1% chance of missing coronary disease, when most of the other studies, you could have maybe 15, 20%, if not more, of missing obstructive disease. But the problem with the coronary CT, especially when there's a lot of calcification, is that you do have low sensitivity. So when there's calcium, we call what we call blooming artifact, you're going to end up saying it's a severe lesion when it actually may not be. And then, so when you use coronary CT as your initial evaluation, if you don't select the patients appropriately, you may end up sending more of them for invasive evaluation compared to the functional testing. So that may be a downside. So that's why patient selection is very appropriate. The US guidelines basically say if somebody's above 65 or prior revascularization, then you shouldn't be using a coronary CT. Those are not hard and fast rules, but a general guideline, because you know that those patients are more likely to have a lot more calcium. That if they've had a prior chest CT, then great. You can always look at that and see how much calcium they do have prior to, so that you could know whether they are good candidates for a coronary CT or not. Just the same thing looking at the specificity and sensitivity. I just added this one because this one had some information for CMR perfusion studies, which again are very similar to the other functional studies if you take out the exercise ECG testing. So when you do this test, we kind of quote unquote a warranty period on them, you know. So if somebody comes to me, they had a normal stress test, but they're having new chest pain symptoms, so that warranty period is about 1 year. Some of the follow-up, especially on the nuclear stress test, goes to about 2 years. So I'll say 1 to 2 years. But a normal coronary CCTA, this says 2 years. I think that's a little bit, I would say if you had a normal CCTA with no plaque or stenosis, I think the warranty period in the real world will be actually more than 2 years. Same with a normal coronary angiogram. But you also always have to evaluate the patients and see what risk factors they have and whether they may be high risk for really aggressive progression of coronary disease. So in conclusion, I hope I've been able to convince you that imaging plays a critical role in the management of atherosclerotic cardiovascular disease, and really deciding what the initial test is to look for obstructive CAD depends on the clinical likelihood of disease, patient characteristics, local expertise, and really availability. All right, thank you. And I don't know whether I'm pausing for questions, but once again, I want to thank you for this opportunity to present this topic.
Thank you very much, Dr. Hermaku, for this in-depth presentation of the modalities available to us. We have many of these, virtually all of these available to us here now. Of course, there's some hitches, technically speaking. For example, when it comes to the nuclear imaging studies, because of the low numbers, we have to queue our patients, get a certain number before we run the test, which may not always be in the best interest of the patient. Anyway, so many of us have had experience with these things, so we'll take questions. Yes, Professor Jenny.
Yeah, thank you. So thanks for that excellent lecture. I've got a comment and two very quick question. The comment is that with patients with typical angina and a positive treadmill test who have apparently normal CT scans, there was a paper presented and then published only a few weeks ago by a UK group demonstrating 100% correlation with microvascular disease using CMR. And that was I must say, I was always very skeptical, but that paper was very convincing. So the old style true syndrome X patients are back again with, so if you have very typical angina and they do have clear-cut positive treadmill test, then you should be thinking of microvascular disease. That's a comment. My question is twofold. Firstly, do you practically have an age cutoff yourself? I know some hospitals will not do CT CAs with anybody over the age of 65, as you mentioned. But in your practice, do you do them yourself? That's the first question. And then the second is, I want you to help me with a 50-year-old smoker who I saw last week, who weighed 180 kilograms with, I know we are not supposed to use the term atypical angina, but he did have atypical angina. Could you kindly help me with that patient?
All right, so yeah, those are excellent questions. So it's true, yeah, because now we are aware of it. We are getting more into a lot of microvascular disease and also just the whole concept of INOCA, which is ischemia with no obstructive coronary artery disease. So that is absolutely. And then from the studies that we have, CMR perfusion and PET perfusion could give you an idea non-invasively looking at coronary flow reserves if you could do that. Though some patients have to end up with invasive testing to be able to diagnose that. So the answer to your question, I don't have a strict age cutoff for me. I kind of look at the patients and look at their risk factors. If I think they have a lot of risk factors, then I'll be hesitant. But some patients may be 70 with very little risk, but maybe all they have is some mild hyperlipidemia and some hypertension presented with chest pain. So I do still do coronary CTs in patients over age 65, but I look at them carefully. And again, if they do have a prior chest CT, always try to look to see whether they have any coronary artery calcification. Your last question was, or let me see, your second question, the first one was a comment, was on a 50-year-old with, and you said, weight how much?
180. 180. 180.
Hello?
180. 180.
Oh boy, yeah.
And that's no exaggeration. It's not Professor Hyperbole. He did weigh 180 kilograms.
Yeah, that's a tough one. So it's as you said, we are not supposed to use the word, but American guidelines have from 2021 have discouraged us from using the word atypical chest pain. But I know what you mean. It's sounding more like a non-cardiac or not a classic anginal symptom. Yeah, so it all depends on their risk factor. But at that age, they do fall into, if you just go by pretest probability, they do fall into a moderate pretest probability because he's over 40, he's a male, and he's having some chest pain. So certainly, we could do a myocardial perfusion imaging study on that patient for evaluation. A stress echo will probably not do, and if you have CMR perfusion too, you can. What some people do, but generally the US guideline only allows us to do that in people who have a low pretest probability of disease, is just to do a plain coronary artery calcium score to see how much plaque they have and whether that will, if they don't have a calcium score of 0, then you could do what we call defer further testing. So I think for that patient, I will opt for either a PET study, which used to be ideal, better than SPECT in obese patients, but availability is limited. So I would go for a SPECT or CMR perfusion study. Yeah, coronary CTs too. once they are obese, BMI above 40, we've been pushing it a little more because of better imaging. But once your BMI is above 40, that also limits the quality of your CCTA images. So I will not offer a CCT on that gentleman as well. Yeah.
Thank you. I think we can take one or two more questions. Yes. Are there any questions in the chat box? No.
Thank you very much. My first question is, what's your expert opinion with respect to interpretation of the coronary artery calcium score in patients who have been on statins for long? And also, do you think there will be a role in using strain analysis in patients who have had history suggestive of acute STEMI, ECG changes, but troponins are negative, and you want to make a decision whether it's because without troponins, by definition, you've not necessarily diagnosed an MI, but is there a role for using the LV strain analysis to help make such a decision? Thank you.
All right. So to answer your first question, if patient is on the statin, it's your question you are asking is, are they on do I have more in terms of let me put it this way, am I going to change their management in terms of up titrating or getting them on more lipid-lowering therapy? And then that will be the only reason to really do that. We generally do it for people who you are initially trying to make a decision to put on a statin. But if somebody was on a statin and you were concerned maybe that you may be sub-optimally treating them, you could potentially do that, but I don't think that's the real role for that. If somebody's already on a statin and they are doing well, I don't think I will generally do a coronary CT on those patients, because most of the time that's where you're trying to do the test to see whether they will benefit from statins. Yeah, unless I'm trying to think about a scenario if they have maybe a very strong family history, and you're like, maybe they should be on high intensity statin instead of moderate intensity, and you want to look at that, then you will do that. But even that, you probably just want to go aggressive and say, hey, I don't need to drop your LDL below 70 milligrams per deciliter by giving your family history with some, maybe I want to do that, but I'm not sure whether there's a lot of benefit in doing a coronary CT on somebody who is already on a statin. And your second question, I'm not sure whether I understood you completely in terms of the use of strain analysis for somebody who comes with chest pain but was ruled out for an MI. I don't know, maybe you may have to repeat the question for me to be able to give you an appropriate answer.
So a patient has come in with history suggestive of myocardial infarction. ECG is showing ST elevation in, let's say, inferior leads, but your troponins are negative. Can you use the strain to help? Because without the troponins, you may not be able to make
that's not
and pathway.
Okay. All right. But are you considered they could have unstable angina? So I'm not too. I guess if you use strain analysis, it could help you pick up regional wall motion abnormalities if you're dealing with unstable angina. It's a lot more sensitive in terms of picking up early changes in the myocardium compared to looking for frank regional wall motion abnormalities. So I could see some role in there if you were to look at that and you realize that maybe some segments of the myocardium have some low strain values, then that could factor into your decision-making process in terms of where you want to proceed in terms of further evaluation or management.
Hello, Fafa. This is Alfred Doku here.
Hello, boss.
How are you?
I'm well, thank you.
You need to arrange for a talk with our fellows here in Ghana when you're on a visit.
All right, absolutely. I'll be more than glad to do that.
Okay, so I have two questions. One has to do with echo, showing that the patient has, regional wall abnormalities, especially when they have heart failure, they have left ventricular systolic dysfunction, and that is a common diagnosis where we say it's ischemic heart disease, and you do a coronary angiogram or CT coronary, it tends to be negative. We tend to do cardiac MRI because then if it's not ischemic, it's able to tell which type of disease it is. So from your experience, what do you normally do when somebody comes in with left ventricular dysfunction, with regional wall abnormalities? Which modality do you normally go for? My second question has to do with CT coronary angiogram. I think CTs are very common in Ghana, and we're getting a lot of CT coronary angiograms, and then they tell us critical disease, we go in and it's normal. I don't know whether it is and I think most of the reports are coming from radiologists. Do you think that if we have more cardiologists who would understand, these disease processes, looking at the clinical history, ECG, and all that, would that help in terms of the yield, because we're having a problem. Just last Wednesday, yes, we went in proximal LAD disease, so we went in Wednesday and it was negative. What advice would you give us to give us a better yield in terms of CT coronary angiogram?
All right, okay. Right, yeah, very good question. So it's the first question, it still depends on the pre-test probability of CAD in that patient. If that was CTL smoker, diabetic, hypertensive with LV dysfunction, regional wall motion abnormality, I probably will be going with invasive evaluation as an initial test, because I think that, but if this was a 40-year-old with not significant risk factors and those abnormalities, I think that's where MRI really is very helpful, because if you do MRI with perfusion, if there's an MI, or you could pick up the wall motion, if there's a myocardial infarction, even very small, you'll pick it up. And also it could tell you whether there's ischemia. So I think in that setting, it will be a good gatekeeper in terms of who goes on to get an invasive angiogram. So that's why it's always very important to really put these patients in one category before, and that will help you one way or the other. So that is so. I think when I did my MRI training in London, and they even with LV systolic dysfunction, if they pretest probability low, you do a good study, no MI, no perfusion, you feel very confident that this is a non-ischemic cardiomyopathy who doesn't need any invasive evaluation. In the United States, we tend to use a little more. Most people with LV dysfunction will end up, if it's below 40%, will end up with an invasive angiogram. Not all, but it's it's something we do more commonly. But I totally agree with you that using CMR in some of these patients will be a good gatekeeper in terms of preventing unnecessary coronary angiograms, which are expensive, yeah, no matter how you look at it. The coronary CT, that is the biggest problem we have with the coronary CT, the specificity. And really, yes, because it's arguable that if it's a cardiologist who is reading it, you obviously look at, when I'm reading coronary CTs, I don't just read a study, I look into what else is going on. Have they had something else done? I factor all those in the decision-making process. So understanding that may put me at some advantage, but I think the real skill is to be able to be identified that though there is significant plaque, there is no significant obstructive disease, and that just comes with experience. So unfortunately, if you have a coronary CT in the hands of an experienced person, that's what will happen. You see a lot of normal coronary angiograms, which is just the lack of expertise. And so I don't want to say that a radiologist can't be. I think there are some excellent radiologists who are very, very good at reading, but I think it's really the key there is to be able to use a coronary artery calcification. Yeah, here we can do what we call FFRCT, so that if you see a lesion and you're not sure, you send it. It's not ready, or you got to send it to a company called HeartFlow, and then they will be able to tell you whether it's significant or not. But we do that more on intermediate lesions. So I think hopefully one day we'll get photon imaging, and then this issue with coronary CTs will be. But I see the false positive rates when you go for angiography with coronary CT. Yeah, that's a big problem. Yeah. So we just have to get better at identifying people who may have a lot of plaque but not obstructive disease.
Well, thank you very much, Dr. Hermeku. You have really focused our attention on the modalities available to us. We have tended to be restricted more to the less expensive investigations. But keep in mind what you have said this morning, we will extend our view to include these other more expensive ones, being selective, as you have pointed out. Thank you very much for your presentation. Thank you.
Thank you. My pleasure.
We shall now continue with a presentation by a pharma company. One Pharma, if you are ready.
Hello. I'm trying to see how it works over here. Hello, everyone. Can you hear me? Okay. Hello, everyone. Can you hear me? My name is Arize from Nigeria. I work with GE Healthcare. I handle the cardiovascular ultrasound portfolio. I've been doing that for quite some time now. And it's great to be back here again. So today I'll be talking about, sorry, can I see the slides instead of myself? Okay, thank you. So I'm going to be talking about, I have a very brief presentation, but at least to let you all know that we have AI tools now in cardiovascular ultrasound that can help you improve the productivity of your cardiovascular processes, cardiovascular ultrasound processes. So, and also I'm talking about connectivity too. I don't know if you've heard about EchoPack, for those of you who are familiar. Yes, so I'm going to go through it and just let you know how it can improve your practice with the tools that we have now. So, first of all, oops. I'm supposed to be talking about digital and I can't even figure out. Okay, thank you. So, generally, this is a summary of the challenges you have in echocardiography, and everything really has to talk about how high the workload is, and the costs that direct and indirect costs from the sonographers who 90% of sonographers complain about musculoskeletal disorders. Echo exams result in 10 to 15% of echo exams have suboptimal imaging. The US population is projected to have some form of cardiovascular diseases, 45% of them, and 108 million annual echo exams performed globally annually. So it just shows you the size of the market, the size of the cardiovascular ultrasound market, and everything that is going on there. And the reason why we need to have productivity tools that can help you either increase revenue, but also increase efficiency. So I know that many times in different hospitals, and I'll speak for the hospitals I'm familiar with, like Nigeria, where there's so many people, so you put them on queues. You say, okay, you know what, your echo is on the last week of this month. And that person has some, that's not what he bargained for, right? But he has to wait. Or he has to go somewhere else to do an echo in some center that might not be doing the right thing. So these are the things, these are the problems you usually have. Now, if you have tools that would improve your productivity, that will mean that if you usually do 10 patients, you probably will be able to do a lot more. And we'll look at one or two of those tools and let's see. So, okay. This, oh, I see. I'm supposed to face it to you, right? I guess, okay. I'm learning. So, one of the tools, the most interesting I find, and I think everybody can easily relate with it, is what we call the AI Auto Measure 2D. Now, AI Auto Measure 2D is basically a tool to measure ejection fraction in 3 clicks. So imagine how many clicks in all the different machines you use you need to do ejection fraction. On the average, 18 clicks. So there's a reduction from 18 clicks to 3 clicks. Freeze, measure, auto. This, of course, you're going to collect the image first. And you're going to have a set of measurements, just like that. And it gives you ejection fraction value. This is based on I'm not going to tell you that there's this algorithm that you put into the machine and all that. The people that manufactured it know why, and they're keeping it secret, right? But this is what you want to get. And I'm just telling you that you can imagine how much this will save in costs, in time, in whatever it is that you're doing in your hospital. You can have a lot more, you can attend to a lot more patients. So it just changes the whole narrative. So these are the tools that we have now, and that's why I'm here. I came all the way to tell you this so that you can buy the equipment. Don't buy the other ones even. So we also have the AI Auto Measure Spectrum Recognition with, again, just 2 clicks, freeze measure. It gives you an automatic Doppler spectrum. You don't have to do any tracing. Of course, you can correct if you want to, but it's usually, as it says there, 98% accurate. So it's probably more accurate than what you would do. So, and it, once you do that, it gives you also a set of measurements as well. So all the time that you're spending doing all the things you have to do, it also reduces, inter-observer variability as well. So, you're afraid to let someone else do some measurements because you have to come there, you're the master of echocardiography and all that. I mean, with AI, it's not really going to make a difference. Do you understand? So everybody's going to get about the same thing. Yeah, I mean, I know that we're still masters of, we still have the big professors and everything who will have to adjust here and there. But I'm just saying it increases your confidence when you're having people work with you. You don't have to be afraid all the time. So these are all the things that it helps you manage in your hospital, in your practice. And then the other tools we have, cardiac auto Doppler. These are very few. There are actually many of them. I just wanted to use a few examples to show you that this is actually true and it works. So on equipment like, even on the low Vivid T9, Vivid T8, the newer ones, because nobody should ask me to upgrade the old ones. It's not upgradable. But the newer ones, from the R6 upwards, you have those tools. So you have all these AI tools that help you to get this measurement easily. So, like I said, the lower interoperator variability, accelerated workflow, and also the accuracy is also another thing that you get that the AI tools help you with. So another thing again that we have, I mean, these are the AI tools. We also have connectivity tools that help you to be able to do a lot more. So we have the Echo Pack, like I was talking about. And, many other companies have platforms, cardiovascular ultrasound platforms that they use. But the difference is that GE saves its images with something called the raw data. So GE doesn't save the images itself in your machines. And that's why you can do post-processing. That's why you can adjust all these parameters So if you look at the screen, you see all the parameters, and I think it's all the parameters really that you can adjust. So your anatomical M mode, 2D M mode gain control, freeze and unfreeze, sign speed adjustment, color map variant, whatever it is, all the things you use, you can actually adjust them, right, on a different platform, on the EchoPack. So you can move the images you can move your images from the scanner itself to the EchoPack platform, which is downloaded on a laptop and we call it the EchoPack software. So on a laptop or on your computer, whatever it is. And then you can move the images there, and then you can do all the measurements you would have done on the main scanner. You're impressed. So, but it's the truth. I mean, many other people will just allow you to you move the images there, you can view them, you can probably move them around, but I'm saying the measurements you make, all the measurements that you would have made on the scanner, you can make on the EchoPack. So what does that mean to you? It means that a cardiologist could have physiologists working with him who will acquire the image and send it to his office, right, where the EchoPack is on his laptop, and he's doing the measurements. This is one use I can think of. There's so many other things you can do. But that alone shows you that you don't need to be there all the time. So for those of you, I'm not a cardiologist, but those of you who work in different places, for example, right, you probably don't have the time to be able to do everything you would have been able to do. What happens is that, you tell them, okay, just acquire the images and I'll pick them up, I'll do all the reporting and send it back to you. That makes everything a lot easier for you. Yeah. And it's not cheap too, but sorry. I'm scaring you. No, it's actually way cheaper than a scanner. So yes, and apart from that, this image is possible because our images are saved in raw data, which means it's not the image, so you can still do post-processing on the raw data set itself. So that's what you're moving from one platform to the other. You understand? And then reprocessing as an image. So it allows you to be able to adjust all those things. Only GE has this, nobody else. So, and I'm not lying. It's actually only GE. So because of time, I don't want to waste too much time. You can actually connect these tools. That's okay. You can actually connect this EchoPack to other third-party EMRs, for example. So you can actually save it as DICOM. You can move the images and save as DICOM on the third-party packs. You can save it as DICOM on third-party EMR and all that. Just to let you know, they're open standards. Yeah, so that's basically everything. I'll just show you. Okay, I've already said all this really, but basically, you can do post-processing. It has open standards, and then you can also integrate with other third-party solutions. So yeah, that's about it. I'll just show you. This thing takes a while. So this is an example. So you have the Vivid machine. You can move the raw data images, the patient data to the platform where you have the EchoPack stored. And then you can, of course, store the images. You can review and analyze. You can do your reports. And you can do research as well, advanced research. You can share this information across different places and all. So it makes things a lot easier. And that's about it. Thank you very much. He has a question.
Yes, so thank you, G. I think, Kolebu, we've bought 4 machines from you. 2 at the cardio center, and then 2 at the medical block. I think Vivid 8, and then Vivid 9. And we've had this discussion with the EchoPack for some time, and I think it's time we operationalize it. Because we need this for training, so resident can take images, they want a quick look, and then say, go ahead, yes, it is okay, And also even for presentation. Cardio, every morning we make 7:30, we have presentations, and want to show images, and then it's a bit difficult. So I think the Echo Park, I know the price, and I think we need to move forward. The question is the Vivid 8, can we also use the AI, or it's not possible? Because we have two of them, Vivid 8 in cardio and Vivid 8 at the medical block. So I think you have to support us. Where it's not possible, you have to upgrade at your cost for us. Because we are a teaching hospital. We need support. We need training to be able to do a lot more. And you can use as a test case. You build capacity in Africa to improve echo turnaround time and for training and all that.
Well, for lack of time, I'll come
back. No, you have enough time to answer.
But we'll look at it. I'm not sure about the T8, but the T9 maybe. But I'll tell you what you can do, really. If you have the Echo Pack, you can use the AI tools on the Echo Pack. At my level, that's the best I can do. If you want to do any real upgrade, I'll advise you not to be honest. Because the upgrade path is entirely different. Yes. But let's see what we can do with the Echo Pack, and then we can. Definitely. I'm always there for you. I know it's how to happen this time. All right. Thank you very much. Thank you, everyone.
Thank you very much. Thank you very much, One Pharmacy. Most interesting. All right. So we are finished with the first section of our presentations for today. We are now moving on to the abstract sessions. And our first presentation will be by Dr. Abdul Suber Yakubu, and he will be presenting online from Tamale Teaching Hospital, quality of care and inpatient outcomes of patients seen with acute coronary syndrome at the Tamale Teaching Hospital.
Good morning, everyone. Please, can you hear me?
Yes, doctor, we can hear you very well.
Okay, thank you very much. Good morning, Mr. Chairman. Good morning, everyone. My name is Dr. I'm a cardiologist at the Tamale Teaching Hospital, and I'll be presenting this abstract on the quality of care and inpatient outcome of patients seen with acute coronary syndrome in Tamale Teaching Hospital. So African countries are facing an epidemic of cardiovascular diseases, and sub-Saharan Africa is not left out. The incidence and prevalence of coronary artery diseases in low to middle income countries is fraught with a lot of challenges at all levels of the healthcare structure. And then the information of the quality of care received by patients in these settings is anecdotally, but we have limited evidence of the quality of care. So in this paper, we sought to assess the in-hospital outcomes and extent of compliance to evidence-based care for patients presenting with ACS in Tamale Teaching Hospital. So this was a retrospective review of patients with ACS presenting from January 2021 to December 2022, which is a 2-year period. We included all adults more than 18 years who had a diagnosis of acute coronary syndrome. A diagnosis was made using standard criteria. Excluded patients who had a myocardial injury or elevated troponins that was due to causes other than acute ischemia. So, for example, patients with chronic heart failure, patients with renal impairment, patients with pulmonary embolism. We tried as much as possible to exclude these cases. with no information on outcome data were excluded, and then those who were discharged against medical advice. So we assess these possible outcomes, and then extent of compliance AJ documents on the clinical performance and quality measures for adults with ACS. This document spells out some minimum criteria that hospitals can use to assess their performance when it comes to management of patients with acute coronary syndrome. So 2-year period, there were 62 patients, the mean age of 56 years, who were admitted for acute coronary syndrome, male. On average, these patients presented at least about 12 hours after symptom onset. So you can imagine that there was a significant lead there. The range was about 15 hours to as long as 4 days. 21 of them had ST segment elevation myocardial infarction. And of these, only 3, that's about 14%, received reperfusion therapy. And this took the form of thrombolysis, because Tamil Teaching Hospital is not a PCI capable center. This thrombolysis was predominantly kinase on account of cost consideration. 3/4 of the patients received dual antiplatelet therapy at the time of discharge, with even fewer receiving high intensity statin. And these 3/4 refer to patients who had no contraindication to dual antiplatelet therapy, but only 3/4 of them had it at the time of discharge. Fewer patients were on high intensity statin, about 2/3 of them. Now, only 38.2% of the patients had their left ventricular systolic function documented at the time of discharge. And if you understand the period of this stage, resident cardiologist in Tamale Teaching Hospital, so echo was not really available. So that might account for this low number. If the study was repeated today, it would be much higher than this. Rehabilitation program in place. So for that score, it was 0% there. And if you look at the records for patients who had non-ST elevation myocardial infarction and acute coronary or stable angina, the risk stratification, GRACE and the TIMI score was not part of routine care, so it wasn't documented in these patients' records. So this table just shows the summary of the results, and whether other cardiovascular risk factors in these patients. And most of them presented with chest pain. About 2/3 chest pain was a presenting symptom. So this table here looks at the performance and then the quality measures. If you look at it, measures that involve percutaneous coronary intervention, such as time to primary PCI, you can see that it was we could not score, not a PCI capable center. But even a measure like time to fibrinolytic therapy, this referred to patients who presented within the appropriate time and who thrombolysis. None of them received it within 30 minutes of presentation. And the 3%, the 3 patients who didn't receive it within this critical time period. So you can imagine there were even significant delay in the thrombolytic therapy. Yes, and a measure such hopefully that will change, but currently we don't have a registry for these patients. And I recall this point was made yesterday by Dr. Adadi. These guidelines measures. So if the performance measures were those evidence-based ones which could be used as a measure of the hospital performance. Quality-based ones, at the time that they wrote the guidelines, they're supposed to be measures that individual hospitals could improve their outcomes, but which at the time was not, the evidence wasn't very strong. But these measures can usually be promoted to performance measures if more evidence become available. And you realize that the scores for complications, heart failure was the commonest, 38.7%, and we had 7 deaths. So we conclude that acute coronary syndrome remains a challenging issue, especially in northern Ghana. There are several gaps we identified in the quality of care, the timeliness of intervention, and then the availability of rehabilitation for these patients. So these are all areas that can be addressed. And what this study does, it just gives us a snapshot of what current practice is, and then gives us opportunities for improvement. So there's an urgent need for measures to improve the quality of delivery of acute coronary syndrome alongside primary prevention strategies. Thank you very much.
Thank you very much, Dr. Yakubu. I hope you're all noting your questions down. We have 5 abstract presentations, which will take less than an hour. At the end of that, we'll take all your questions together. So just jot down your questions, and after the 5th presentation, we'll go on to a Q&A session. Our next presentation will be by Dr. George Pepra. And this is live. This topic, comparative echocardiographic assessment of cardiac function among, there it is. You can read it on the screen. So over to you, Dr. Pepra. Thank you.
Today. Still not. Okay. Good morning. I thank the organizers for this privilege to present the abstract on the work that I did. So before the slides come up, my work was basically to compare the cardiac structure and function of patients with chronic kidney disease and those with hypertension, but no evidence of having developed chronic kidney disease. And something, a simple question I would like to ask is, will you do an echocardiogram for any patient presenting to you with a diagnosis of chronic kidney disease? Is this something that you routinely do? That once the patient has come, you know he's developed chronic kidney disease, you just go ahead and do echocardiogram? And if you do, why? Okay. So my main work was to compare the prevalence of cardiac abnormalities in patients with CKD stages 3 to 5 to those with just hypertension. And then among those with chronic kidney disease, I also explored if there was any association between the cardiac abnormalities I was examining to age, diabetes, dialysis, or CKD stage. The hypothesis was that as the patient age increases, it may increase the prevalence of these cardiac abnormalities, as well as those with diabetes, those on chronic kidney disease will also likely have more of the cardiac abnormalities I was assessing. And that increasing CKD stage may also increase these cardiac abnormalities. So the heart and the kidney has a very important relationship that has been known over the years as the cardiorenal syndrome. And the axis I mainly assessed was those with chronic kidney disease, going on to develop cardiac abnormalities as a result of these abnormalities. So patients with chronic kidney disease, they may have dialysis. They may also have some risk factors such as diabetes, and then they have a uremic medium. They also have an inflammatory medium, and aging and other things. All these may influence the heart to go on to develop left ventricular hypertrophy, left atrial enlargement, diastolic and systolic dysfunction, pericardial effusion, and then pulmonary hypertension. So this was more or less the theoretical idea behind the study that I did. So what I did was to compare 78 CKD patients to 83 hypertensive patients, and I excluded those with known chronic abnormalities such as congenital heart disease, restricted the study to those 30 to 75 years. And then among those with hypertension, those who had abnormalities such as proteinuria, hematuria, which are signs of kidney damage, were also excluded for that arm. So the results of the study showed that the prevalence of the left ventricular hypertrophy, left ventricular diastolic dysfunction, the left atrial enlargement, and pericardial effusion were significantly higher in patients with stages 3 to 5 compared to those with purely hypertension. There was, however, no disparity in the prevalence of pulmonary hypertension and left ventricular systolic dysfunction in these two groups. And again, increasing CKD stage increased the prevalence of the left ventricular hypertrophy, left atrial enlargement, but not the systolic or pulmonary hypertension. And patients in stage 5 CKD also had more severe forms of diastolic dysfunction, mainly grade 2 and grade 3 diastolic dysfunction. The other factors that were tested, which were age, being on dialysis or diabetes, did not make any significant change among these two groups. So these were the figures that were obtained. So for left ventricular hypertrophy, the hypertensive patient was 16.9% of them compared to 55.1% among the CKD arm, and it was statistically significant. So in conclusion, patients with chronic kidney disease showed higher prevalence of left ventricular hypertrophy, and it was mainly the concentric type than those with systemic hypertension. So take away from this study, this information underscores the significant impact of chronic kidney disease on cardiac structure and function, and emphasize the need for comprehensive cardiovascular assessment and management in CKD patients. The findings underscore the need for heightened awareness and comprehensive cardiac assessment in patients with CKD to detect and manage cardiac abnormalities early. It also suggests the potential for a more aggressive approach to cardiovascular risk reduction and monitoring in CKD patients, especially as the disease progresses. So the question again, will you do an echo for every patient with a diagnosis of CKD? Thank you very much.
Thank you very much, Dr. George Pepper. Again, let me remind you, jot down your questions for the QA at the end of the presentations. Our next presenter will be Dr. Richard Day, and he'll be talking on evaluation of cardiac structure and function among student athletes at the University of Ghana.
Thank you very much. I also would like to thank GSC for giving me this opportunity to do an abstract presentation of my dissertation. And also, I would like to use this opportunity to thank all my senior colleagues who are my mentors and then teachers who helped me through this process. Now, there has been a raging debate as to whether it is economically viable to screen athletes, because what happens is that if you screen a cohort of athletes, rarely will you find any abnormality. But there are two schools of thought. One school of thought thinks that it is important to do it. Other schools of thought think that, well, it may be chasing after the wind. But the most important thing is that a death that happens as a result of sporting activity is observed worldwide. So it is a death that happens whilst you have the whole world looking at the stage. For instance, in a sporting activity that is going on, and I guess you are aware of situations happening during the World Cup, a patient collapse, a footballer collapsing, and then eventually passing on. So it is important that we continue to do this. The other thing is that, as you are also aware, we recently lost one of our footballers on the field whilst playing soccer. So this study focused on evaluating the cardiac structure and function among student athletes at the University of Ghana. Basically, emphasis was placed on looking at the ECG and echo pattern, because in certain instances, these changes may exhibit similarities to pathological changes that may appear on the ECG. Hence, the need to distinguish between a pathological change and that of normal adaptation as a result of training. So it was a comparative cross-sectional study with age and sex match controls. We took the baseline demographic and clinical characteristics and then did a comprehensive examination. We took the history and then did physical examination. We followed up with an ECG and then an echo for each of the participants. And then we did an analysis of the mean and multivariate logistic regression and association. So the results of the findings, when we looked at the ECG, approximately 47% of the student athletes show some ECG changes, and these changes includes premature ventricular contractions. There was one patient, one athlete, was 21 years, who had atrial fibrillation, and then there were others who have ST changes, T-wave inversion, bradycardia, and left ventricular hypertrophy using the Sokolos index. In all these changes, males were 4.6 times more likely to have an ECG change as compared to females. This month, there was a release by Professor Sanjay Sharma in the St. George's in UK, which also showed that if you look at master athletes, these are athletes that have been practicing the trade from their youthful age into their late 60s. And they've realized that the males are still those who have the tendency of having some cardiovascular events in the sporting fraternity. And we also look at the abnormalities in the ECG pattern based on the type of sports that they were involved in. And it was found that we have dynamic and static sports presenting with the highest number of abnormal ECGs. When we did echo, the geometric transformation or adaptations that we saw were concentric left ventricular remodeling constitute about 36.5%, concentric left ventricular hypertrophy 33.9%, and then eccentric left ventricular hypertrophy 8.7%. This was significantly higher than the control group. LV geometric changes. In the echo that we did, none of the factors that we looked at in terms of type of sports, duration of training, and gender were significantly abnormal in the student athletes. So in conclusion, student athletes exhibited abnormal ECG changes with the male gender identified as the only predictor of abnormal ECG. Echo findings were more prevalent in the student athletes as compared to controls. An implication of this study, it means that routine screening is recommended for early detection of life-threatening cardiovascular conditions. Importance of gender-specific consideration should be applied when we are doing cardiac screening for these student athletes. And what is the future direction? To expand this research to cover other universities and regions, longitudinal study for tracking cardiac changes over the time. When I was doing this study, most of the findings were in black athletes that are not in the sub-Saharan region. Most of them are the Caribbeans or African Americans in the US. So if we are able to do this, for instance, if we take the university, at least we can follow them for a period. So you have level 100, you can start, do a baseline for the athlete, and then probably while they are exiting the university, you can also do these investigations, and that may give us an idea of the pattern of the changes that occur in this period over that, in these athletes over that period. And this can help us also see what pertains in our sub-region. So the takeaway of this is the study highlights the need for regular cardiac screening in student athletes, identify potential cardiovascular risks early, and prevent sudden cardiac death. Thank you.
Thank you very much, Dr. Day. Our next abstract will be presented by Dr. Bobby Safo, Clinical Profiles of Heart Failure in Pregnant and Postpartum Women Admitted into a Tertiary Hospital in Accra.
Afternoon now. Good afternoon, and I would also like to follow in the steps of my previous presenters to say a big thank you to the organizing committee for this opportunity to present my findings in this study. I also want to thank the senior members and lecturers who helped and all the inputs and advice and direction to finally come up with this results. Actually, this study was inspired by one that was done by a predecessor of mine. He looked at clinical profiles of heart failure in adult patients seen at the Department of Medicine. And I remember as I went through his study, one of the exclusion criteria was pregnant women. And I said that, oh, why don't I also look at what is causing heart failure among pregnant and postpartum women? So, and then with the encouragement from Dr. Doku, we went ahead. So, you can go to the first slide. Okay, yes. Do I put it to the device? Okay, thank you. So these are the authors of okay. So by way of introduction, cardiac deaths from heart failure during pregnancy and the postpartum period is an important indirect cause of maternal mortality. And when we talk about indirect causes, it's causes that are not directly related to obstetric causes. Those are the direct causes. And currently, there's quite limited data in our country about heart failure during pregnancy and the postpartum period. So the study sought to assess the etiology and also clinical presentation of heart failure among pregnant and postpartum women admitted to the Kolebu Teaching Hospital. So this study, like I said before, it was carried out in the obstetric wards of Kolebu Teaching Hospital, as well as medical department. So the obstetric wards were the antepartum and immediate postpartum women. You know that usually they will be observed for a number of days before discharge. Whilst the Department of Medicine, we looked at the postpartum patients, that's up to 6 months. So my inclusion criteria were pregnant women and then postpartum women within 6 months of delivery. So some of these were seen in the medical block of Kolebu Teaching Hospital. So it was a cross-sectional study. We recruited a total of 131 patients. Actually, within a period, about over 14,000 pregnant women presented to the Kolebu Teaching Hospital. And we got 135 women with heart failure, but 2 of these were excluded because they had they had end-stage renal failure, and so they were excluded, and 2 of them did not give consent. So we got 131 patients, and they were selected based on suspicions of heart failure using the Framingham's criteria. So a structured questionnaire was used to obtain details of history, physical examination, as well as electrocardiographic and echocardiographic findings. And then it was analyzed using IBM SPSS version 24 software. So for every statistical study, we found a p-value of less than 0.05 at a confidence interval of 95 was considered statistically significant. Okay, so the results within the period, we found the prevalence of heart failure in pregnancy was 0.9%, or 9 women in every 1,000 pregnant women that were seen. Yeah, and the commonest risk factor for heart failure among the participants was a past history of either pregnancy-induced hypertension, preeclampsia, or eclampsia. So these women were this risk was like patients who had a previous PIH in a previous pregnancy. So they were the highest number of, that was the highest risk factor that we came across. And then we also found that peripartum cardiomyopathy was the commonest etiology of heart failure in the Kolebu Teaching Hospital. And then also the commonest ECG finding among these women was sinus tachycardia. Sorry. So also we realized that the patients with peripartum cardiomyopathy, just as expected from literature, they had predominantly heart failure with reduced ejection fraction. And then also we found the period of time from delivery to the end of the puerperium, that is 6 weeks after delivery, to be the highest risk period for cardiac decompensation. So about 65% of all the patients who presented were within this period. That's from delivery to 6 weeks postpartum. That's 65% of all the patients were within this period. So we realized that this was the high risk period for cardiac decompensation. Okay. So these are just a few 3 or so images that I put, just showing about 52% of all the patients had peripartum cardiomyopathy. Then we had those who had established hypertension, chronic hypertension. They presented with hypertensive heart disease, and then we followed by patients with pregnancy-induced hypertension. So these were the etiologies in reducing frequency. And then also talking about the risk factors or the associations. So like I said before, 52% of the patients had had a PIH in a previous pregnancy. So like in a prior pregnancy, they had PIH that they were completely cured. So in the index pregnancy, they had entered the pregnancy without any high blood pressure or anything of that sort, but they just had a previous history of PIH. So that was the highest risk. And then we had people having personal history of chronic hypertension, and then current history of PIH, and then family history of hypertension. So these were the 4 highest risk which were seen. Okay, so this was what I talked about. You could see that majority, that's from, this should have been at delivery, sorry. So 21% presented with the symptoms of cardiac decompensation during delivery, 18% presented around 0 to 2 weeks postpartum. Then we had about 2% presenting 2 to 4 weeks, and another 23. So the highest group was around 4 to 6 weeks postpartum, 23.7%. So when you take this group, that's from time of delivery to 6 weeks, they make up about 65% of all the patients who presented. So that period was the period of the highest risk. So in conclusion, pregnant women with a previous history of PIH were at highest risk of developing heart failure within the puerperium. And then for that matter, strict surveillance is needed on this patient's population during pregnancy and the early postpartum period. Thank you very much.
Thank you very much, Dr. Safo. We now proceed to the final abstract presentation for this afternoon, and it will be delivered by Dr. Sheila Amate Atukwefio, cardiac abnormalities among systemic lupus erythematosus patients in a tertiary hospital.
Thank you. Thank you very much. Thank you very much for this opportunity. Okay, the title of the study is Cardiac Abnormalities Among Systemic Lupus Erythematosus Patients in a Tertiary Hospital, a cross-sectional study. So the background, systemic lupus erythematosus, SLE, as we all know, is a multi-system autoimmune connective tissue disorder involving multiple organs and systems. And although cardiovascular involvement in SLE has been found to be a major cause of morbidity and mortality in this group, they are rarely screened for. So this study sought to determine the prevalence of cardiac abnormalities among SLE patients and its association with the modified SLE disease activity index. This is a tool that is based on the various clinical manifestations of SLE, and then they are scored and then categorized into whether the patient has mild SLE disease activity, moderate, or severe. So the, sorry. Oops. Sorry. Okay, so the methods. So this was a cross-sectional study of SLE patients with no known cardiac abnormalities at the Kolebu Teaching Hospital from June to December 2021. And the baseline demographic and clinical characteristics of the participants were obtained, and a detailed transthoracic echo was performed for all of them. The prevalence of common cardiac pathologies were determined and compared with those with high disease activity and those with low disease activity. The results, so 99 SLE patients participated in the study with a mean age of 35 years. Majority of them, over 90%, were females, and the mean SLE disease activity score was 9.1. 35% of them had mild to moderately active disease, and 39 had severely active disease. So about 66 out of the severely active disease group had abnormal echo findings, whilst 28 of those with mild to moderate disease had abnormal echocardiographic findings. The common echo abnormalities that were found in the group, 47 of the patients, in total, 47% of the patients had echo abnormalities, and about 8.7% had valvular involvement. 15% had diastolic dysfunction. 5.2% were found to have left ventricular hypertrophy, and 0.9% had left ventricular systolic dysfunction. And then also 12% had pulmonary hypertension, and 1% had pericardial involvement, which comprised pericardial lesion and pericardial thickening. It was found that there was a significant association between disease activity and echocardiographic abnormality in the participants. Out of the patients who had low disease activity, 3 of them had abnormal echo findings, while as much as 56% out of the severely active disease group had abnormal echo findings. The odds of echo abnormalities were up to 13 times higher in SLE patients with high disease activity as compared to those with low disease activity. There was, however, no significant association between cardiac abnormalities and the duration of SLE. So in conclusion, cardiac abnormalities are indeed common in SLE patients, and echocardiographic assessment should be considered in the management of SLE patients. It has to be decided whether it's worth it to do an echo for all SLE patients at the point of diagnosis as a form of baseline, and then possibly repeated when they have flares, because that way we'll be able to pick up those at risk of cardiac disease and those with cardiac problems before the complications become dire. Thank you very much.
Thank you very much, Dr. Tukwefio. I'll ask the other presenters to please come up here, and we move on to our Q&A session. I hope we have Dr. Yakubu online.
Yes, please.
Dr. Pepra, any questions in the chat box? So we'll now take questions. Yeah, let's take one mic down, please.
Right. Right, thank you. My first question goes to Dr. Day. So, from the presentation, it came out that the student athletes had more abnormal echo and ECG findings as compared to the normal student population. Aside the male that was identified as a risk factor, I'm wondering why we had more student athletes having these changes. And so I wanted to find out whether there was anything that maybe through the research you identified as possible risk factors that increased the risk for student athletes. Because I'm thinking that if student athletes get to know that they are at a higher risk of developing cardiac arrhythmias and stuff, I don't know what's going to interest them anymore to go into it. So I mean, that's my first question. Then the second one.
Just hold on. You'll
Okay.
answer the first one.
All
We'll
right.
give you an
Okay.
opportunity to.
Okay, thank you very much for the question. So, in this study, I would say that it's a baseline study. The population size that we used was 115 athletes and then 115 on groups. So these are ECG changes. Because it is an abstract presentation, there's actually a criteria whereby you have training-related ECG changes and training unrelated ECG changes. So these abnormalities come out. After you see them, what happens is that it is not for you to say that you have an abnormality, but there are ECG changes that may point either way. So what you do is that you go on to further do some other investigations to be able to determine whether those are training-related changes or they are changes that can predispose the individual to sudden cardiac death during training or participating in a sporting activity. So it is not as straightforward to say that, okay, you have an ECG abnormality. No, and then you shouldn't partake in the sporting activity. There are stages that you take these individuals on, and eventually it's a shared decision that you eventually take as to whether the individual should continue the sporting activity or not. But there are situations where you, the clinicians, may come in and advise strongly if, for instance, your finding shows that this one, the risk is high for the person to stop the sporting activity.
Yes.
Okay. All right. Thank you. My second question is for Dr. Bobby Safo. So it said, your presentation pointed out that previous history of PIH or preeclampsia or eclampsia is the highest risk factor for developing cardiac failure in pregnancy in the postpartum period. And you indicated that surveillance should be increased. I wanted to know in which form this surveillance should take, whether it would mean that if you have a patient who has pregnancy, who has a past history of pregnancy-induced hypertension or preeclampsia or eclampsia, immediately you should involve a cardiologist from the get-go, or are you supposed to, what exactly does the increased surveillance mean with regards to that? Thank you.
So thank you very much for your question. So what, like among my recommendations, with these patients, as you know already, most of the time, the patients in our environments, when they are treated with some of these PIH, especially during pregnancy, when they are discharged, sometimes there's no definite follow-up for them. You know, sometimes they follow up 2 weeks postpartum, and then there's a 6 weeks postpartum visit, and then that is it. So there were actually 2 specific recommendations I made in the study. The first one was to possibly think of increasing the number of postpartum visits for this particular patient population, because you realize that the greatest number of cardiac decompensations were occurring between 0 and 6 weeks. So for these patients, instead of 2 weeks postpartum visits and 6 week postpartum visits, if we could make it, for instance, fortnightly, it was one of the recommendations. And then secondly, too, there is an obstetric medical clinic now in the Department of Medicine, where they kind of liaise with the obstetric department. So after 6 weeks, when these patients are being discharged, you know, prepartum cardiomyopathy, for instance, can occur anywhere up to 6 months. So when these patients are being discharged, they could actually be referred to this obstetric clinic, even those that are stable, you know, those that the babies are okay and for kind of monthly follow-up. So after the 6, 7 months, and then you know that nothing is going to happen, and then you can discharge them. So these are 2 clear recommendations that I made.
Thank you.
Yeah, hello.
Good afternoon. Thank you very much to all the presenters once again. I have a question to Dr. Pepra, one to Dr. Day, and then one to Dr. Bobby Safo. So, Dr. Pepra, in your, I just wanted to find out from your work, thank you very much for the presentation, was there any sub-analysis to evaluate the findings between what was the underlying factors for the CKD or the predisposition to the CKD? Did it influence in any way these concentric and eccentric changes that you saw on the echo? Or are there plans to do further analysis to whether or not CKD underlined by hypertension or diabetes or any other cause really plays a role in cardiographic changes? I'm asking this because we do know that those with established peripheral artery disease or atherosclerotic diseases, about a third or more of them have underlying cardiovascular or will have an underlying cardiovascular problem. So whether or not this CKD, the cause was related. The other thing to, the other question to Dr. Day is, I don't know if I missed it, but then I saw changes on ECG with the commonest being the PVCs and then one atrial fibrillation and all that. Were they, those who had abnormalities in the ECGs, were they the same people or were there any relation between those who had the echo findings as well? I don't know if there was that analysis, but I don't remember. Maybe I missed that part, sorry. So if you could delve into that for us. For Dr. Bobisa, for...
2 questions enough. Well,
yeah. Thank you. So, with the exclusion criteria, I tried to exclude most of the confounding variables as much as I could. But there are certain factors which will be almost impossible to do. And that was mainly hypertension. Because indeed, all the CKD patients have hypertension in the study that I did. So hypertension was sort of baseline. For both sides, there were hypertension. So if the differences that were seen, i.e. the CKD group having more abnormality could be attributed to the fact that they had CKD on top of the fact that they had hypertension. So hypertension alone could not be used because both sides have it. And the baseline characteristics of both arms were very similar in terms of age, sex. In fact, there was age and sex matching during the sampling period. So that too could not be an explanatory variable. Another factor that could be is diabetes. And again, both sides were similar in terms of the number of patients with diabetes on the hypertensive arm compared to the CKD arm were similar. I didn't show that one because this was just for the abstract, but if you read the study and then look at the baseline characteristics, they were very similar. The only thing that was different was the creatinine level, which was, the main work of the study, which was trying to get more people on the CKD arm having stage 3 to 5. So that was the main thing that was different. But what you are saying is true. Confounding variables cannot be brought to zero, but as much as possible in this study, their baseline characteristics were quite similar. Thank you.
Thank you for your question. So those factors that I put there are changes that were observed. But if you see one PVC in an athlete's ECG, it doesn't make it abnormal. So I just indicated that those were found. But when you see those ones, there are, for instance, if you see an athlete
burden, then you can categorize that patient as that athlete as abnormal. So those were the changes that were seen in those population of athletes.
So, Dr. Day, just a point of clarification, maybe you can say there's this concept of the athlete's heart, where there's certain ECG changes which the ordinary observer may be classified as abnormal, but in an athlete are actually normal. Would you make a comment on that?
So those, the issue is that those abnormalities, for instance, if you take endurance athletes, something like bradycardia is a common finding in endurance athletes. But what happens is that if you find bradycardia in an athlete, that is a training-related change. Then what you want to do is that you go further to ask questions in terms of symptoms, whether there are some symptoms related to what you are seeing, or you look at your echo and see if there are chamber dilatations or the extent of the remodeling that has taken place. So you put all these together. As my senior colleague said, there is this concept of athlete's heart, which comes as a result of the increased demand that is put on the heart during the period of training. And these are adaptations that are normal. But there are some of them, what happens is that they may be signs of an overt or occult cardiac abnormalities, which you have to try to interrogate further so that you can prevent this individual suffering sudden cardiac death during training or participating in a sporting activity.
Thank you. There's a question. You can bring the mic over. When you get the mic, please tell us your name and then proceed to ask your question.
All right, thank you very much. My name is Dr. Isifu Amwaba. I'm a cardiology fellow in training. My question goes to Dr. Richard. Whether you consider the duration of how long did one have to be an athlete, and then did it have any effect on the outcome? And then the other thing is that a student athlete, were we looking at those who were athletes only in school, because some would be athletes in school and then maybe probably when they go on vacation they stop. Because I remember I was an athlete when I was in GHS, but I did that for just 1 week. After I ran my first 100 meters, I resigned immediately. So I don't know whether all these things were, consideration was given to all this, and whether the duration, and what even the definition of an athlete is in our environment.
So the duration was taken into consideration. There is what is happening now is that the sporting fraternity in the university is becoming very competitive now. So there are situations where we have the sport directorates going out to actually scout for these athletes at the SHS level, and some of them are even giving scholarship. If you are an athlete, you are given scholarship running and all those things, you are not considered as an athlete. You have to have a regular, so there are several definitions. Sometimes they say the individual trains for at least a number of hours per week. So a minimum of 4 hours per week will classify you as an athlete. And you are doing this with the intention of competing against other individuals.
Now, your paper seems to be generating a lot of interest. I hope people are not looking for an excuse not to do their morning 30-minute walk. Can we bring the mic over to? Is the mic out there somewhere? Yes, over here, please.
All right, so I think Dr. Amable, forgive me, commented on the athlete heart issue because one of the things I had wanted to ask you. But on a lighter note, I assume that most of your patients, most of your participants are unmarried men, isn't it? I don't know the details of your demographics.
The age range of my sample size is 18 to 35.
Oh, 35, they could be married, but I don't know whether you looked at that. But on a lighter note still, with my assumption that most of them are unmarried, and they are athletes and active and all of that, and yet have cardiac abnormalities, what do you say to the men who blame their heart diseases on their wives?
Oh, you can answer on a lighter note.
What angle is the blame coming from? Let me answer.
No, I think the issue of men having issues and dying earlier than their wives, I think goes beyond what Dr. Day has presented. I have taken a personal interest, you know. I have several widows in my clinic, and then you ask them what happened, and then they have all kinds of reasons why the men are dead. And 20, 30, 40 years on, the women are still alive and very healthy, you know. So the issue of blaming the wife, I think, needs to be looked at because there's a cause and effect there. And I think that the men are dying early, and then they give all kinds of reasons. I have decided that, yes, I have to give my own reasons. In fact, I'm going to see my lawyer, record some of my, my life issues, and then kept so that when I die, whoever queries my wife, what happened to your husband? Then this tape will be given out, and then the person, because some of the women will say, look, the man was chasing several women. So several reasons that are given, and unfortunately the man is not there to explain things for himself. But certainly something is going on, and I think there are widows, and they live on 30, 40 years after the men are dead. But what is happening to the men, we need to interrogate. And of course, some men marry younger women and several things, but there's a huge gap in terms of knowledge. What is killing our men? The men are dying young, and the women still live on. And I think this study cannot explain it. We will need a bigger study to really find out why the men in Ghana, in Africa, are dying young, and the women are dying 40 years after the men are gone. Thank you very much.
Thank you very much.
Thank you.
To add to what Dr. Amable said, the usual physical activity that we are encouraged to engage in improves our cardiovascular health. Athletes do 10 to 15 times what we are required to do for our cardiovascular health improvement. So that, again, should not be the excuse not to exercise. Thank you very much.
One more question.
Okay, it's a question and a comment. And I think I have to congratulate the organizing committee and an association, Dr. Kokro, and the other executive for really bringing this part of the scientific and then, in general meeting. I think let's clap for the association. this is an excellent, innovation, and I think most of those presented are cardiologists, new cardiologists, and the work they did, and this is a high-quality work. I know from us, I think from Kolebo, 8 cardiologists who came out. I think one had 2 publications out of the thesis. Dr. Atukwe has 1 publication from her thesis, and then one has just been submitted, I think, this week. Others have been submitted. And I think I would encourage the others also, because this is high-quality, scientific work. And sharing this is very important, but sharing it with a bigger, world community, scientific community, is something that is, I would encourage. Dr. Bobby Safo, I know you're doing a prospective component of your work, trying to see the outcome of this heart failure on the baby, on the mother. And I think that's also another thing that you should continue so that in the next AGSM you can present us. So thank you for the work that you're doing.
Thank you. And with that said, thank you, Dr. Doku, for saying it on my behalf. I add my voice to your comments, and I'll congratulate all of you for your excellent presentations and encourage you to keep up the good work so that we build up the cardiovascular community in the country. Thank you all very much. Thank you. So we proceed with the presentations. I don't know if Xavier is ready. We have a presentation from here.
Hello everyone, my name is Cecilia Kisi, and I'm a pharmacist from Xavier. As I wait for my slide, I'll try and be engaging you. So today I'm going to propose a solution. I'm not loud enough. Please, can you hear me? Okay. So today I'm going to be proposing a solution for optimizing the management of your hypertensive using our triple fixed dose combination triple exam. I mean, this is something we are already familiar with. So this few minutes, I'm just going to reiterate on the key benefits that your patients will still be getting from us. So I'll start off with the burden of hypertension in Africa. Okay. So currently, hypertension still remains a burden to us. Recently, a global report on hypertension in the WHO just this September shows that we still have 20 million people living with high blood pressure, and out of the 28 million people, 11 million are have just been diagnosed. Out of the 11 million that have been diagnosed, we still have just 3 million being treated. Out of the 3 million being treated, you have about 2.5 million people still uncontrolled. So this is like a real burden to us. Coming down to our country, Ghana, recent publication shows that our prevalence is also high, still between 20 to 55%, with a BP control rate of 10 to 32%, which is still very low for us. And some of the factors that have shown to negatively affect this control is high burden pill, and the fact that most people have been diagnosed 2 to 5 years since their diagnosis. The Institute Health metrics and evaluation also reiterates what we already know is the trend. There's been a constant increase in death due to hypertension in Ghana. The recent evolution of death has been so high in Ghana, and primarily for people aged between 50 to 69, the primary cause of death and dialysis still remains high blood pressure related issues. And they also reiterated the fact that currently you have about 60% of stroke death, IHD, CKD, they still attributed to high blood pressure, 40% fibrillation, atrial fibrillation and flatter death, cardiomyopathic death, and the rheumatoid valvular heart disease still being associated with high blood pressure. So this is like a state of an emergency for us to quickly act. And so there has to be that rapid intensification with the good protocol. And the key thing is, if there's an improved global blood pressure control of greater than 50% or more, it will avert about 76 million cardiovascular deaths, 120 million strokes, 79 million myocardial infarction, and 70 million cases of heart failure between 2023 and 2050. So the time is now for us to act to ensure a better future for us. And then the European Society of Cardiology has also put together the algorithm to help us in fighting this race against the red zone. And so this is something we are already doing for your patients that would need a triple therapy, recommending a fixed dose combination, which is rather preferred as compared to the single pills. And so you have the option of doing the ACE inhibitor, ARB, CCB, and then a thiazolide diuretic. And they are very strong on recommending the thiazolide diuretic as a more potent option, like indapamide. So our conventional thiazolide diuretic like bendro or hydrochlorothiazide. So that is why I am proud today to introduce to you the first and only indapamide-based phase triple combination. It has 3 complementary modes of action: the ACE inhibitor perindopril, inhibiting the angiotensin II, the amlodipine acting on the vessels, blocking the calcium channels, resulting to vasodilatation, and then indapamide, the thiazolide diuretic with the dual activity. Over 90% of indapamide's action is on the vessel, causing enhanced vasodilatation, and just 5% at the kidney level. So in real life, I'm still in the moment of being proud with our triple exam. It's still the first and only perindopril-based phase combination. And this is a new publication that came out just September 2023. This was not a severe study, actually. It was done in Africa, South Africa, and I mean, with South Africa, actually we can relate. So this was a real-life study. It was an insurance company in South Africa that initiated the study. They wanted to find out among 3 categories of RAS inhibitors, which one would be more financially beneficial for them. So the treatment was based on perindopril, losartan, and then enalapril. It had about more than 63,000 patients. It lasted for about 5 years. The main aim was that for all these patients who are on a perindopril-based combination, losartan or enalapril, they wanted to find out, for the primary criteria, the myocardial infarction, coronary heart disease, heart failure, and stroke. Secondary criteria was all-cause mortality, risk of hospitalization for one of the primary endpoints. And at the end of the 5-year study, they realized that a treatment based on perindopril, whether monotherapy or a fixed dose combination, actually gave a better clinical and financial results as compared to losartan and enalapril. And this has facilitated the perindopril being on their national drug formulary, and they recommend patients to be given perindopril-based combination in order to protect them in the future. So in terms of your clinical assessments, what are you getting for your patients? Right from the first 2 weeks, triple exam is giving you a powerful blood pressure reduction. You can get as high as 23 millimeter mercury in just 2 weeks of therapy, and after 3 months, you can expect as high as 48 millimeter mercury reduction. Also, with whatever stage your patient presents with, whether stage 1 or 2 or 3, you realize that the BP is adapted to the initial level. The higher the BP, the higher the control. So you can get as high as 53 millimeter mercury from baseline for your patients with stage 3. In addition to that, whatever drugs they were on before you switch them, whether 2, 3, or in some instances, we've seen patients on 4 drugs still benefiting from triple exam. And then before you switch a patient to a triple therapy, I'm sure they will be on various combinations. So we also prove that regardless of the combination, whether ACE or ARB, they will still benefit from triple exam. So in effect, after 3 months, you have 8 out of 10 of your patients being at target goal, which is a very good one for us. What is power without sustainability? So triple exam, the components of triple exam, which is covered amlodipine, indapamide in their class, is the best. And they also present with a high trough to peak ratio, which represents the efficacy of a drug in a 24-hour period. So you realize that there's that sustained blood pressure control, and this is very key for our early morning strokes and heart attacks due to high rise in BPs. So you still have that control over a 24-hour period. Okay. In addition to this, you are getting a strong blood pressure cardiovascular protection, as was seen in our advanced CCB, where we reduced total mortality by 28%. And currently, triple exam is the only fixed dose triple combination that gives you the best cardiovascular outcomes, as was seen in the Brisgella study, where comparing it to other triple therapy, there was less 2 times incidence of cardiovascular events. So in conclusion, for your patients that you need triple therapy for, whether those uncontrolled on dual therapy, triple therapy, or in some instances, we've seen patients on 4 drugs not doing well, being controlled on triple exam, you choose one of the 4 dosages of triple exam for flexibility of dosing. Thank you. And I'll be at my stand for further clarification if time doesn't permit. Thank you.
Thank you very much, Xavier. For the last 2 days, we've been here considering various topics related to the question of atherosclerotic cardiovascular disease, a silent killer. We've looked at the epidemiology, risk factors, the pathophysiology. We've considered entities like chronic coronary syndromes, stroke. We'll have one more. Okay. Bayer. Do we have the Bayer representative? Yeah. Okay. So a presentation from Bayer.
So, good afternoon, dear doctors. I've been told I just have 5 minutes, so I'll just run through. So Xarelto, we already know 10, 15, and 20 milligrams used for prevention and treatment of venous thromboembolism, as well as prevention of stroke due to non-valvular atrial fibrillation. 2.5 is used with aspirin 100 milligram for prevention of major adverse cardiac events due to coronary artery disease, peripheral artery disease, as well as secondary prevention of major adverse cardiac events due to acute coronary syndromes. Okay. So we are going to focus on patients with non-valvular atrial fibrillation at the risk of stroke, but also suffering from chronic kidney disease. The background to this presentation it's not working. Okay. Okay, so the background to this presentation derives from the Rocket AF trial. So the Rocket AF trial established that Xarelto can be used for the prevention of stroke due to non-valvular atrial fibrillation. And in a meta-analysis with the other NOACs, you can see that Xarelto had the highest CHA2DS score. So more sick patients were included in the Xarelto study, showing that even for high-risk patients, Xarelto can be used in preventing stroke due to non-valvular atrial fibrillation. Now, in building upon this trial was the introduction of the Xareno study. So in the first Rocket AF trial, patients who had non-valvular atrial fibrillation did not have chronic kidney disease. But in the Xareno study, they looked at patients with chronic kidney disease and non-valvular atrial fibrillation at the risk of stroke. Now, the dilemma when it comes to such patients is that warfarin, even though you are looking at anticoagulation to prevent stroke, is still associated with deteriorating renal function. So the issue, therefore, is whether or not there's an alternative, and can that alternative be Xarelto, and what is the evidence to back it? And that was what the Xareno study sought to explain. So the Xareno study was a multi-centered trial. It sought to show that patients with non-valvular atrial fibrillation and advanced CKD can indeed benefit from Xarelto as compared to warfarin. So in that trial, you want to look at the type of patients that were included. Building on the Rocket AF trial again, the patients included had high CHA2DS scores. We are looking at as high as 4.1, 4.0. I mean, a patient with a CHA2DS score of 2.1 already is in serious trouble. How much more someone who is as high as 4? They had comorbidities. Such patients had diabetes, hypertension, congenital heart failure, and their eGFRs were very low. So, yes, please, this final. So I'd like to draw your attention to the eGFR. You look at it, 36.2 throughout. Comorbidities, as I mentioned earlier, hypertension, diabetes, in addition to the fact that they have chronic kidney disease as well as non-atrial fibrillation. So what were the results of the Xareno study? From the Xareno study, there was a composite clinical reduction of the clinical events. So you see that the incidence of stroke was reduced, major adverse cardiac events was reduced by 32%. So this shows that when it comes to such patients with CKD, non-valvular atrial fibrillation at the risk of stroke, Xarelto has superior efficacy. Now let's go to the proof of the pudding. So when it came to the renal insufficiency, such patients had 60% less likely progression to stage 5 chronic kidney disease. This means that as high as stage 4 chronic kidney disease were included in the Xareno study. So it shows that patients on one coin had superior efficacy with Xarelto. And when it came to preservation of renal function, Xarelto was better as compared to warfarin. And I must say, Xarelto is the only NOAC which has been studied in such subset of patients. So you won't get it with the other NOACs. I'm trying to be diplomatic, I won't mention any names, with the other NOACs. So there's also a 92% less likely initiation of chronic renal therapy, which betrays the point that indeed Xarelto is safer when it comes to patients with CKD and non-valvular atrial fibrillation at the risk of progressing to stroke. So the dose in such patients is stepped down from 20 milligram if there was normal renal function. That is creatinine clearance greater than or equal to 50 ml per minute. But due to the renal insufficiency, for such patients, 15 milligram once daily is what is used. And in rounding up, I think our eloquent speakers have spoken about how time is everything. Dr. Adoku will always say time is muscle. When it comes to stroke, time is brain. When it comes to checking of the echoes, time is echo. When it comes to direct oral anticoagulants, please, Xarelto works as fast as enoxaparin, even though it's oral. So therefore, when it comes to oral anticoagulants, time is Xarelto. Thank you so much for your time.
Thank you very much, Beya. I think that was the last presentation. Yes. Right, so in summary, we have looked at the topic of atherosclerotic cardiovascular disease over these last 2 days. We've looked at the basic science behind atherosclerosis and the effects of this process on the heart, on the brain, kidneys, the arteries of the legs, and the arteries of the penis. That was a fantastic presentation yesterday. Those who were not here, you really missed something. At the end of it all, I think enough information has been presented to justify the classification of atherosclerotic cardiovascular disease as a silent killer. And with this information, it is our sincere hope that we all go back to our stations with a heightened sense of awareness of this problem and a greater commitment to tackle it wherever we may be. The pharmaceutical companies have also chipped in by telling us about products that they have which will help us tackle this entity, and their input has been very useful. But above all, perhaps the biggest weapon we have is preventive medicine. This means taking a hard look at the risk factors. We have non-modifiable factors that nobody can do anything about. But when we come to the modifiable risk factors, it comes down to a matter of personal choice. And we as healthcare providers need to advise our clients, our patients, and also lead by example in the choices we make. So when we look at things like alcohol and tobacco, I think tobacco, the case is cut and dried. Very few people indeed indulge in tobacco use today. But alcohol is still there. And for those of you who are still clinging to it, there was a recent publication debunking the supposed benefits of red wine. Maybe you all have a chance to look it up, and it's not a game changer yet, but it hits at our commonly perceived notions about some of these factors. When it comes to diet, we are faced with choices every day, and it is up to us to make proper choices which will promote cardiovascular health. Nothing left now but to thank the organizers for having put together such an informative and useful and well-planned program. Kudos to the local organizing team and to the executive of the GSC. Let's do it better for them. A round of applause. And with that, it is my pleasure to declare the end of the scientific aspect of this meeting. I'll now hand over to the executives, the organizing committee, to tell us what comes on next. Congratulations. Thank you very much.
I'll give the vote of thanks and then we can proceed to lunch. It's been a long journey. Last year, I was selected as the LOC chair, and I was given some few colleagues to work with. Myself, Dr. Jifa, Dr. Akuto, Dr. Emanuela, Dr. Lambert, and then we started the journey. It's been back and forth. We had a lot of contribution from the previous LOC chair, Dr. Yawedu Boache, and then we set off with our team for the program this year. And then we went ahead, looked for presenters, looked for chairmen and all that. And then at periodic intervals, we had to interact with the GSC executives. and it's been a long journey, but I'd like to express our appreciation to all of you here for coming to grace the occasion and all those who contributed in making the 2024 Ghanaian Society of Cardiology AGSM a success. I thank you all for your time, for your contribution, for your dedication to this particular association. And I pray that the good Lord takes you to wherever you all came from safely. And hopefully we'll meet next year and the appropriate venue will be communicated to you. We thank you all for helping this AGSM to become a success. Thank you very much, and God bless you all.
Okay, thank you. I've been given the mic by the LOC chair. I don't know why he's giving it to me, but I guess he wants me to talk. Yes. Okay. So I will just add my voice to the LOC chair and say thank you very much for your participation. It's been good, and I'm overwhelmed. I'm told that we are about 90 plus here and outside, even though we had made room for only 60. That gives credence to what you guys want to learn. So we thank you so much. We thank our presenters. We are going to have the AGM after lunch. That one is for members of the Ghanaian Society of Cardiology. So we want to say all the Ghanaian Society of Cardiology members, those online, those in here, will come back at lunch and quickly do our AGM, and then after the AGM we'll be able to communicate to all of you where we are going to have our next AGM. So thank you very much. But before I put on the mic, I want us all to give a very big clap to my father and my mentor, Professor Podonu. If you notice that he was here yesterday very early. He was here before about 90% of the people that were in here. Today too, he's been here throughout. It's amazing to always see him and the enthusiasm with which he pushed the agenda of cardiology in Ghana. So Papa, thank you very much. A special thank you to you. Thank you very much. God bless you all. Thank you.
Thank you all. We will all proceed for lunch. Thank you.